السلام عليكم.
عليكم السلام.
وعليكم السلام دكتور.
الله يحفظك استاذنا ويبارك فيك، يعني هذا اقل الواجب.
وعليكم السلام sir.
How are you guys?
Alhamdulillah, fine sir. How are you sir?
الحمد لله.
Yes, fine.
نعم.
Ramadan Kareem.
Ramadan Kareem to you sir.
الله أكرم. الله أكرم.
Okay, today inshallah we will start resuscitation. All resuscitation stations are interesting. If you understand the approach, it will be very easy to practice. Better in resuscitation or in examination. So you have two-station resus, you have two-station examination. Okay, two-station resus, two stations number 6, 7 resus, number 8, 9 injured patient means examination. So for station in the exam, try to be fast and your voice loud. Some people can control themselves. They are not stressed when they are fast. They are not stressed when they raising their voice. If you feel this will affect you, try to be normal. If you feel you cannot be fast, no problem. Try to be normal. Even if you feel better for you to be slow, no problem. Don't worry. But I'm talking about the ideal approach for any examination or any resuscitation. Okay? Because you are saving lives. If the patient you are taking history, number 1, number 2, number 3, number 10, it's history. It's not a big issue, especially if the station irrelevant to heart. For example, the patient has headache, okay, or the patient has leg problem. So here you are taking history, no problem. You are not fast, okay. So before they said mandatory to pass one resuscitation. This rule not available, not applicable now. Okay. So even you did not pass resus, no problem, don't worry. So the most important to get the bus score, yes. But of course, we are not planning for the bus score only. We are planning for very high score. Okay. Inshallah, resuscitation will take 3 sessions. So ALS 1 session, then ABLS and the newborn. Next session will be ABLS and the newborn resuscitation. The following session will be ATLS. Our schedule in Ramadan, as I found the suitable time is 12 UK time. Okay, 12 p.m. UK time. Okay, it will be suitable for almost all people in all countries. I mean, this is best time. Even it's not suitable for some people, but at least this is best for most. I mean, okay. Clear, guys, the timing?
It's okay sir, it's okay.
Yeah.
12 again, please. 12 p.m. UK time, Saturday, Monday, Wednesday. If we have additional session in on Friday, we will mention earlier. Okay, so system and joint will take also 2 sessions. Practical skill teaching may be 2 or 3 sessions. Communication may be 2 or 3 sessions. Then mock exams till the exam, inshallah. Just to remind you, you have 5 domains. Accuracy, it means you should mention all the points in the checklist. We will give you the general approach for all categories. Skillfulness should be fluent. Efficiency structure should be organized. You should follow the same arrangement of checklist. Supportiveness, it means in history or examination, good eye contact, then check comfortability, pain, address symptoms, then questions or information in basis, rapport, empathy, sympathy. So what about resuscitation? Resuscitation here, it means your voice should be loud and you should be fast. What else? You should check the monitor, your eyes on the monitor, your eyes on the patient, your eyes on the actor, nurse or nurses, okay? Safety, correct information. Correct information, it means a correct assessment, correct findings, correct call, correct intervention. How many points, guys?
4 points.
Yes, correct assessment, then correct findings plus diagnosis, then correct call, then correct interventions in each system. Okay. Um, the general approach for resuscitation will be the same for ALS, ATLS, APLS with a small modification. Okay. These are the stations in Resus for ALS, ATLS, APLS, and the newborn. Newborn, it means within 24 hours. Newborn, it means within 24 hours. Whatever the baby just born now, I mean 0 minutes, or he has 24 hours age. Okay, so you should follow newborn resuscitation. If the patient, if the patient has age more than 24 hours up to 18 years, we are calling
Child.
ABLS,
ABS, yes.
not a child.
Okay.
Not a child.
Okay.
ABLS. Okay, again. So within 24 hours, we are following what?
Newborn
Newborn
resuscitation.
resuscitation. More than 24 hours, up to 18 years, we are following what?
ABLS.
ABLS, pediatric. Okay. More than 18 years, we are following
ALS.
ALS. Any trauma, we are following
ATLS.
ATLS. Any trauma, whatever newborn, or whatever pediatric, whatever adult, we are following ATLS. But in MRCEM OSCE, they will not give you trauma for any pediatric. So any trauma in MRCEM OSCE, it will be for adult. Okay. And final OSCE, maybe. Okay. So when to start resuscitation? When to start resuscitation? In ALS or ATLS or pediatric resuscitation, we are following resuscitation if the patient has no signs of life or has irregular breathing, or the patient has irregular breathing. Okay. Do you have trauma and cardiac arrest in MRCM OSCE? No. So they will not give you pediatric trauma and they will not give you cardiac arrest and trauma. In final OSCE, they can give trauma and cardiac arrest? Yes. Okay. Clear this point, guys?
Yes.
Okay.
Yes, sir.
So when to do resuscitation again in ALS or ATLS, or pediatric, if the patient has no signs of life or irregular breathing. Okay. When to do resuscitation for newborn? What do you think, guys?
If Apgar score is 0,
If Apgar score is low, like for example less than 3 or less than 4, okay. So Apgar score, it means, for example, no pulse or pulse less than 60, okay, and no breathing. These 2 points of 5 points of Apgar score. So Apgar score, it means appearance and then blah 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 blah, okay. So two of them, pulse and breathing. So in pediatric, if the pulse less than 60, in pediatric, not in newborn, in pediatric, if the heart rate less than 60, is it arrhythmia or cardiac arrest?
Cardiac arrest.
No,
Cardiac
arrhythmia.
arrest.
Arrhythmia. In pediatric, don't mix pediatric and the newborn. In pediatric, if the heart rate less than 60, is it arrhythmia or cardiac arrest?
Bradycardia, arrhythmia.
Bradycardia, it means arrhythmia. But if heart rate less than 60 in newborn, what does it mean?
This arrest.
Cardiac
Cardiac
arrest.
arrest.
Clear now the difference?
Yes, sir.
Okay. The ALS, the ratio would be 30 to 2. 32. In pediatric, ratio is 15 to 2. Okay. And in newborn, the ratio is
3 to 1.
3 to 1. What if pediatric but neonate?
3 to 1.
3 1 also. Clear? So whatever newborn or neonate, the ratio 3 to 1. So newborn and the neonate, same ratio, but not same resuscitation. Clear? Not same resuscitation. Okay. So today we will practice sepsis, GIT bleed, chest pain, whatever STEMI or pulmonary embolism, anaphylaxis, hyperkalemia, poisoning or overdose, TCA, calcium channel blocker, opiate, lidocaine toxicity, hypothermia, rapid sequence induction if we have time before breakfast, intubation in cardiac arrest. If we have time to practice rapid sequence induction and intubation in cardiac arrest, we will do. If not, we will practice in mock exams. We have for practice today نجلاء فقيه، بسمات، علي، جيفانا، أحمد، كاليان، نجلاء جاد، مزمل، إيمانويل، عمار، أنور، and عمر. Okay. The general approach, you have 6 points. Introduction, then hand over from ambulance crew and or relatives. So you will take handover from ambulance crew or relatives. Then ABCDE, then hand over to relevant specialty, then reassess ABCDE. Okay. Then discuss with your team. Regarding ABCDE, what does it mean ABCDE? Mannequin. What does it mean ABCDE? Mannequin. So before mannequin, what you will do? Hand over, you will do introduction and then hand over from ambulance and the relatives. Then you will do mannequin, ABCDE. Then what you will do after mannequin?
Hand over.
Hand over to.
Specialties.
So before mannequin, hand over from. After mannequin, hand over
To the relevant specialty.
Clear now?
Yes.
So you will receive the patient, you will receive the mannequin from the ambulance, manage the mannequin, and then hand over, deliver to a specialty. Easy?
Yes, sir.
You will receive the patient from the ambulance or from the relative, from the mother or from the father, then manage, do resuscitation, then give to a specialty for admission. Easy?
Yes, sir. Easy.
Okay. Mannequin, it means A, B, C, D, E. This is the first A, B, C, D, E. It means it should be full. You will do full assessment. After assessment, you found the findings. You should verbalize them. Findings, it means you found diagnosis. You should mention. Then you have to call. then you intervention. Clear this point? So intervention here, number 4 or number 1?
Number 4.
Number 4. So don't do any intervention until you assess the patient, until you verbalize the findings, until you verbalize the diagnosis, until you call the relevant specialties. Then you will do your interventions. For example, the patient needs chest drain. No, you don't insert a chest drain now. You can say, what about blah, 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 blah. Then finding the patient has deviated trachea and hyperresonant and blah, 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 blah. It could be tension pneumothorax. Then call trauma team and cardiothoracic surgeon. Then intervention, needle in the 5th intercostal space, then chest drain in the 5th intercostal. Clear this point? How to manage?
Yes, sir. Yes, clear.
Yes, sir.
Okay. You finished airway, you finished the breathing, you finished circulation, you finished disability, you finished exposure. Then you want to hand over this patient to relevant specialty. Then you will do reassessment. Reassessment, it will be brief because already you finished. This is the second assessment, will be brief. Brief assessment, you will ask about the previous abnormalities. Then you will verbalize brief findings. Then brief call, you can confirm. For example, you call the trauma team and the cardiothoracic. Then here you can confirm. You can say trauma team and the cardiothoracic arrived, like that. Then intervention. If you need to do further intervention, do. If no further intervention, ignore. Okay. Then you can discuss with your team about the diagnosis, about what you did, about the next decision, for example, admission. All people of resuscitation for admission. Clear? All people for resuscitation, admission. If the patient has any problem in airway or blood gases, okay, and you feel not responding to basic airway maneuvers, again, patient has problem in airway or blood gases, not responding to basic airway maneuvers, then you will go for non-invasive ventilation or invasive ventilation. Invasive ventilation, because non-invasive ventilation contraindicated in resuscitation. Again, don't use non-invasive ventilation if the patient, for example, drowsy, vomiting, unconscious, hypotensive, and blah, 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 blah. Okay. So what about mannequin ABCDE? So A, B, C, D, E. Regarding airway in ALS and ABLS, you will ask 2 questions. Is the patient conscious? The examiner, if said yes, it means conscious. If he said no, it means not conscious. If the examiner is silent, it means not important. Ignore. The examiner ignored you. You are asking him, is the patient conscious? He ignored you. So no problem. Go for the next step. Is the airway patent? If he said yes, it means a patent. If he said no, it means not patent. If the examiner is silent, what does it mean?
Patent.
Patent. So the only case airway is not patent if the examiner said no, or he said not patent. Okay. So if the examiner said yes or is silent, it means the airway is patent. What you will say? Apply high flow oxygen. Done. If the examiner said no, then try to be simple. Clear airway, oropharyngeal airway, nasopharyngeal airway, apply high flow oxygen. Done. Okay. In breathing, expose the chest, connect all monitors. Ask about how many points?
8 points.
8 points. Try to be fast. What about SpO2, RR, trachea, neck veins, inspection, palpation, percussion, auscultation of lungs and heart? What if you ask the 8 points? No problem. If I am very fast and I said, what about SpO2, RR, trachea, neck veins, inspection, palpation, percussion, auscultation of lungs or heart? No problem. Clear? I can save time. I can save time. Okay. You want to ask one by one? No problem. Two by two? No problem. Okay. So 8 points, it will give you idea about breathing. Okay. So expose the chest, connect to all monitors. What about SpO2, RR, trachea, neck veins, inspection, palpation, percussion, auscultation of lungs and heart? You should ask by this way. It will take 15 seconds or 10 seconds maximum. Good. Clear, guys?
Yep.
Okay. Circulation, 4 points. In trauma, 9 points, but today is ALS, so we will follow 4 points only. What about blood pressure, CRT, peripheral pulses, heart rate? You can ask one by one, no problem. 2 by 2, 4, no problem. Okay. What about blood pressure? We are in circulation now. Blood pressure, CRT, peripheral pulses, heart rate. Okay. What about disability, GCS, any signs of lateralization, pupils, echoreactive? What about blood sugar? Then expose all the body. Any other abnormalities? What about temperature? So, airway, how many questions?
2 questions.
2 questions. Airway, 2 questions. Is the patient conscious? Is the airway patent? In breathing, how many points?
8 points.
In circulation?
4 points.
In disability?
4 points.
In exposure?
2 points.
So, 2 in the start, 2 in the end. In breathing, 8. Circulation and disability, 4. Easy?
It's easy, sir.
2, 8, 4, 4, 2. Okay. Airway, it means from the scalp to trachea. Airway from
Scalp to trachea.
scalp to trachea. It means any patient has any problem in the scalp, in the hair, in the nose, in the eye, in the mouth, in the ear, in the neck. What is your concern?
Airway.
Airway. Whatever ALS or ABLS or ATLS. Okay. Any patient even has abrasion here or here or here. You should think about airway. Clear? Okay. So airway, it means 3 points. Nose, mouth, trachea. Airway means nose, mouth, and
Trachea.
trachea. Nose, natural airway. Mouth, natural airway. Trachea, artificial airway. So if the nose is closed, you will use
OPA.
mouse.
Mouse.
If the mouth is closed, you will use
Nose.
nose. If both of them closed, you will use
Trachea.
trachea. It means you should do surgical wound, artificial opening. Clear?
Yes, sir.
So you have 3 points for airway, 2 natural and 1 artificial. Okay, we finished now airway. Then we will go for breathing. Breathing, it means from trachea to umbilicus. From trachea to umbilicus. Any problem, like a scar, like abrasion, like contusion, like any problem in inspection, in palpation, in percussion, from trachea to umbilicus, your concern is
Breathing. Chest.
breathing. Okay. Then circulation, anything down the umbilicus. Circulation, anything down the umbilicus. It means abdomen, pelvis, 4 limbs. How many limbs?
4 limbs.
So abdomen, pelvis, lower limbs, and the upper limbs. Clear? So what is your concern?
Circulation.
Circulation. Okay. Then disability. What does it mean, disability? The brain. Okay. So airway from scalp to trachea, breathing trachea to umbilicus, circulation down the umbilicus. I'm talking whatever ALS, ATLS, anything. So you should examine like that. Examine from scalp to trachea. Any patient. From scalp to trachea. You finish the airway. Okay. From trachea to umbilicus, you finish breathing. From umbilicus down and check the limbs. Okay. If I say, for example, in circulation, peripheral pulses, you will check how many peripheral pulses?
4.
Four peripheral pulses. Okay. 4 peripheral pulses. Okay. You should, ideally, not for the exam, ideally, you should check the peripheral pulses in upper limbs and to compare, lower limbs and to compare. Then compare the upper with the lower, like that. Okay. But anyway, for the purpose of the exam, just verbalize. What about peripheral pulses? Done. He will say normal or weak or absent. Okay. So we finished now circulation. We'll go for disability. What does it mean, disability?
Brain.
Brain. It means you will ask, what about GCS? What about signs of lateralization? What about pupils? Equireactive? What about blood sugar? Then exposure, it means all the body. Okay. So your position where, when you check the airway, try to be behind the head. When you check the airway, try to be behind the head. Okay. When you check the breathing, right side of the chest. When you check circulation, right side of the abdomen. When you check the pelvis, right side of the pelvis. Easy. When you check the limbs, try to be on the right side of the limbs. Clear?
Yes. Yes.
Okay. Then disability, try to be on the right side of the pelvis, no problem. Exposure, you will be in front of his feet. It means at the end of the bed here. So airway here and exposure here. I wish it's clear, guys. Okay, so we finished now the approach. Then what if the patient, what if the examiner, sometimes the examiner will answer, sometimes the nurse will answer. You ask, is the patient conscious? He said unconscious. What you will say, look, listen, and feel any signs of life. What if he said unresponsive? Again, look, listen, and feel any signs of life. You ask about SpO2, he said not reading. What you will say, look, listen, and feel any signs of life. You ask about RR, he said 0. Look, listen, and feel any signs of life. You ask him, what about blood pressure? He said not palpable or not recordable or not reading. What you will say?
Look, listen, feel for any signs of life.
Look, listen, and feel any signs of life, like that. So you have 4 points. 4 points. If he said patient is unconscious or unresponsive, number 1. Number 2, SpO2. Number 3, blood pressure. Okay. Anything not reading. Anything not reading or not responding. Clear? Since you can say, look, listen, and feel any signs of life. Okay. We will start the massive transfusion protocol. I want to start a massive transfusion protocol if the patient has massive blood loss. Okay, so if the patient is stable, no need to start blood transfusion. If the patient has bleeding and is stable, no need to start blood transfusion. Okay, I want to say massive blood loss, unstable, source of bleeding plus RR breathing more than 30 plus heart rate more than 110 plus systolic blood pressure less than 90. Okay. Here you will understand the patient has massive blood loss. So you should verbalize the patient has blah, 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 blah. It could be massive blood loss. Then call trauma team, call activate massive transfusion protocol, call or prepare the theater or OR. You can say prepare theater or OR. Then you will start the first action. What is the first action? Cross match. What does it mean, cross match? Same blood group. Okay. If same blood group not available, you will give
O negative.
no O blood group. O blood group. Okay. I said O blood group. Why? Because it depends on the gender. If the gender is male, you will give O positive. If the
Positive.
gender is female, you will give O negative. If child bearing period, if the female child bearing period, what if the female postmenopausal? O positive or O negative?
Opposite.
O
Oppositive.
positive. Okay. So if same blood group, how many units?
4 units.
If
Units.
not same blood group, how many units?
2
2
units.
units.
Excellent. So if same blood group, 4 units, because no problem. Same blood group. But not same blood group, you are afraid. You are giving only 2 units. Okay. Same blood group. Okay. Which component? The blood components, we have bagged RBCs, we have fresh frozen plasma, we have platelet, we have cryoprecipitate. So the blood component of all people, how many points?
4.
4
4
points.
points. Number 1, bagged RBCs. Number 2,
Fresh frozen plasma.
fresh frozen plasma. Number 3,
Platelet.
number 4,
Cryoprecipitate.
cryoprecipitate. Patient has massive blood loss. What does it mean, massive blood loss? He lost more than 2 liters. He can die. Okay. So how to stop bleeding? Which component is important to stop bleeding?
Bagged RBC.
Back the RBCs. Only? Yes. So which one? Is it back the RBCs or fresh frozen plasma or platelet or cryoprecipitate?
Bagged RBC.
Back the RBCs only. Okay. Enough to stop bleeding. Then you will give in circulation, in the first circulation. Don't ask about blood pressure after packed RBCs. You can ask about that in next C. Okay. So here you have airway, breathing, circulation, disability, exposure. This first assessment. So A, this is the first A or second A?
First.
First.
First A, first.
B.
B, first.
C.
C, first.
D.
D.
D, first.
E.
E, second.
A.
Second.
B.
Second.
C.
C.
Second.
D.
D,
and
second E. So if I say first C, it means first circulation and first assessment. If I say second C, it means second assessment, second circulation. If I say third C, it means third circulation, third assessment. Clear, guys?
yes.
So you will ask about blood pressure, CRT, peripheral pulses, heart rate. The patient is hypotensive. Then you will start, for example, if bleeding, you will start give 4 units back to RBCs. Of course, after IV access, after extract, after blah, blah, blah. Then in second C, you will ask about blood pressure. Don't ask about blood pressure after giving the back the RBC. You will ask about blood pressure in the second C. Okay, the blood pressure is still low. What you will give?
Primary back.
No, you should ask about blood result first. So in second B, what about blood pressure? He said low. Then ask any blood results. If he said yes, correct the abnormalities. If he said yes, correct the abnormality. What does it mean? If hemoglobin less than 8, give 4 units back the RBCs. If INR more than 1.5, give 4 units fresh frozen plasma. If platelet less than 50,000, give 1 unit platelet. So if he said yes, blood results available, ask him about what? Hemoglobin, huh? INR, and
Platelet.
platelet. Then correct the abnormality. If he said no blood results, then tell him I will give primary pack 4 units RBCs, 4 units fresh frozen plasma, 1 unit platelet. Okay. Then go for disability again and blah blah blah. When you return to third circulation, you will ask about blood pressure. He said low, still low. Then what you will say?
What's the
Blood
any result?
result.
Any blood results? If he said yes, you will correct the abnormalities. You will ask, what is the first question?
Hemoglobin
Hemoglobin. He said less than 8. You will give
4.
4 units.
4 units RBCs, back the RBCs. What about
INR
INR? 4 units fresh frozen plasma. INR more than 1.5, then give. Platelet less than 50,000. Give
1 unit platelet.
1 unit platelet. Fibrinogen here. So he went to ask about fibrinogen in the third circulation. Clear?
Yes.
When you plan to give secondary pack. So you will ask about fibrinogen. He said less than 1.5. Here you should give 2 units cryoprecipitate. What if he said no blood result? Then verbalize, give secondary pack. 4 units back the RBCs, 4 units fresh frozen plasma, 1 unit platelet, 2 units cryoprecipitate. In the next C circulation, you will ask what about blood pressure? He said still low. What you will say?
Any blood result.
Any blood results? He said no blood results. Then give.
Second pack.
You will verbalize them again and then confirm. OR is ready. Team is available. Like that. Okay. So in ALS, you have team ICU team. In ATLS, trauma team. In ABLS, pediatric ICU team. In newborn, neonatology team. How many teams now?
4 teams.
4. So when you say call, today we will say call trauma team. So in sepsis, you discover the patient has chest infection. You will call
ICU team.
ICU team. GI bleed, you will call ICU team and
Enga.
gastroenterology team prepare theater. Clear? STEMI call
Cardiology.
ICU team.
lab.
The team first.
ICU team and cardiology.
ICU team and the cardiologist. Anaphylaxis call
ICU team.
ICU team. Hyperkalemia call.
ICU team.
ICU.
So ICU team, including anesthetist, if in anaphylaxis, if the patient has problem in airway and you diagnose the anaphylaxis, so you can say the patient has hoarseness of voice and blah blah blah. It could be anaphylaxis. Call ICU team, including anesthetist. Hyperkalemia call
ICU team.
and nephrologist.
Nephrologist.
Okay. TCA
ICU team.
and the
contact التوكسيبيز.
toxibase.org. So TCA, calcium channel blocker, opiate, lidocaine toxicity, all of them, you will call ICU team and contact toxibase.org. Hypothermia, ICU team. Okay. Rapid sequence induction, so ICU team, including anesthetist. Okay. So in introduction, try to be very brief. Good morning and blah blah blah. May I know your name and the grade and you? Thank you. Done. If you have one nurse, may I know your name and the grade? Done. Please prepare equipment for airway and circulation. Done. No need to be complicated. Okay. Try to be very simple, very easy. Okay. Very concise. Again, may I know your name and the grade? Nice to meet you. Please prepare airway and circulation equipment. Done. We are waiting for patient with chest problem, breathing problem. We are waiting for patient with hematemesis. We are waiting for patient with chest problem, chest pain. We are waiting for patient with rash. It depends on the scenario. We are waiting for patient with chronic kidney disease. We are waiting for patient with overdose, or toxin. We are waiting for patient with hypothermia. Okay? Clear, guys?
Clear.
No need to talk too much. I don't care about the age of the patient. I don't care about his name. I care about one term. What is the problem? We are waiting for patient with blah, blah, blah. Blah, blah, blah. Done. One term only, one word. Okay. We will start the practice. Okay. Next one, I think Nagla.
Yes.
Okay. So this patient, what is the problem?
Just a problem.
Yes, breathing
Just
problem.
one.
So
Mm.
we are waiting for patient with breathing problem. I don't care about his blood pressure. I don't care about his age, his name. I don't care. Clear? Okay. So you will catch the problem where?
The B.
Breathing. Okay.
Mm.
You will verbalize the assessment, findings, call, intervention in the breathing. Okay.
Okay.
You want me to give idea or you will practice and then give you idea?
I want you to give me idea first.
Okay. So this patient in airway, okay, the patient has drowsy. The examiner said the patient is drowsy. If the examiner said the airway is drowsy and he did not mention airway not patent, ignore. Give high flux. You ask him, is the patient conscious? He said drowsy. Is the airway patent? He repeated drowsy. Then ignore him. No need to ask him again. High flow oxygen. Done. Go for breathing. Then breathing, ask about 8 points. He said hypoxia, trachea central, neck veins normal, and inspection normal, palpation normal, all normal except auscultation of lungs. He said bilateral basal crepitation and heart, normal heart sounds. If heart sounds normal, it means not heart problem. If neck veins are normal, it means not heart problem, not kidney problem. So it's a not fluid overload. Clear?
Yes.
If you have noisy breathing, I mean crepitation, okay, you have three differential diagnoses. It could be lung, it could be heart, it could be kidney. Okay.
Okay.
If the neck veins are normal, it means the lung only. If the neck veins are congested, it could be heart, it could be kidney. Okay.
Mm.
How to differentiate? If they said heart sounds normal, how to differentiate between heart and kidney? If they said heart sounds normal and the patient has kidney disease in the scenario, it means pulmonary edema and the kidney problem. If the heart sounds abnormal and the patient has congested neck veins, it means heart problem. It means fluid overload. It means pulmonary edema, cardiogenic. Okay. So neck veins here important. If I said normal or flat, okay, or collapse, it means it's not heart, not kidney. Clear?
Yes.
Okay. So if the patient has bilateral basal crepitation and nothing kidney or heart, you will verbalize the patient has bilateral basal crepitation, normal heart sounds, and neck veins are normal. The patient has no kidney disease because not mentioned in the scenario. Then you can say it could be chest infection. Done. Then go for circulation. You find the patient has hypotension. So you can say patient has bilateral basal crepitation and hypotension. It could be septic shock. So any shock, you should mention the type. You can say it could be because we have no evidence till now. Clear, doctor?
Yes.
In circulation, you will give fluids, normal saline bolus will be 500 cc. Okay. So in circulation, you will ask, what about blood pressure, CRT, peripheral pulses, heart rate? Then you verbalize the finding, verbalize the diagnosis, and then insert it to IV access, extract the blood for hematology, biochemistry, blood gas, blood culture, toxicology screen. Then you will give fluids, normal saline, 500 cc bolus. Okay. Until now, we have no evidence for what?
Sepsis.
For sepsis. Okay. If you want to ask about blood gases in the same circulation, no problem. If you want to ask about blood gases in the next circulation, it's to say no problem. It's up to you. Clear?
Yes.
So you can ask about blood gases in the same C or the next C. Regarding breathing, you can ask about the X-ray in the first B or in the second B. Clear? Regarding circulation, you can ask about ECG in the first C or the second C. Okay. So in first C, you can ask about blood test, ECG, and the blood results. It's up to you. You want to keep to the next C? I'm talking about ECG and the blood gases? No problem. You should say clear.
Okay.
Okay. So you have 30 seconds and 6 minutes, okay?
Can I start? Yes, can I start, Dr. Hani?
Yes, please.
Okay. Good afternoon. I am Dr. Nagla, the registrar today. May I know your name and level, please? Are you ALS provider? Are you happy to manage airway? Patients, we are waiting for patient with chest problem.
Patient
Patient
arrived.
arrived? Okay. Is patient conscious?
Take hand over.
Hand over from ambulance crew.
The patient is drowsy.
Please apply high flow oxygen and expose chest and connect monitor. What about SpO2?
SpO2 80.
80 respiratory rate.
RR is 40.
Trachea.
Center.
Neck veins.
Normal.
Chest inspection.
Normal.
Chest palpation.
Normal.
Percussion.
Normal.
Auscultation of lung and heart.
Bilateral basal crepitation. Normal heart sounds.
So we have this patient with desaturated and with low oxygen and bilateral basal crepitation, and most probably this patient had infection in his chest because neck vein, not because he had normal neck veins and low oxygen. So we will go to see what about blood pressure.
Not recordable.
Any signs of life?
Yes.
Okay. What about heart rate? Yes, heart rate. No, this is I am seeing sinus tachycardia. What about peripheral pulses?
Weak.
CRT?
9.
9. So this patient had this patient in shock due to low blood pressure, and he has this sinus tachycardia and weak peripheral pulses. So most probably he patient in a septic shock due to chest infection. And please insert 2 IV lines and connect blood for hematology, chemistry, and blood gases, and septic screen and serology, and give 500 normal saline bolus in 10 minutes. And we want to call the ICU team, and we will go after that to D. What about GCS?
This is 13.
Any signs of lateralization?
Normal.
What about pupil?
Equal reactive.
Blood sugar?
5.
5. So I am happy with D. We will go to E, exposure. Please expose all body, any abnormality. What about temperature?
39.5.
So patient had high temperature. This will go with sepsis. insert urinary catheter, and I will reassess the patient again. And what about saturation?
Hand over the patient.
I will hand over the patient to ICU team. This patient came with ambulance, and he's in septic shock. And he had low saturation, and he had basal crepitation, and we need to reassess the patient again. What about SpO2?
SpO2 is not reading.
Any signs of life?
Yes.
What about blood pressure?
What you will do in breathing?
Breathing.
You ask
This
me about
patient-
you ask me about oxygen saturation. I said not reading.
So continue to apply high flow oxygen.
Already
And,
the patient on high flow oxygen.
High flow oxygen, we need to ventilate the patient and connect the valve mask, and we will go to blood pressure. What about BP?
The oxygen saturation is not reading.
Patient already on high flow oxygen, and there is signs of life. About respiratory rate.
Okay, your time done. Thank you. Okay, thank you, Nagla. You should remember hand over before, hand over to after. Clear?
Yes.
You are not the only one doctor in the hospital. Okay. You received this patient from whom? You will deliver this patient to whom? Clear?
Yeah.
And try to be simple. I need to hand over this patient to ICU team for admission. Done. No need to explain too much. Clear?
Clear.
No need to waste the time. If the examiner said the ICU team arrived, here you can talk in details, no problem. So, for example, if they said in the end, ICU team arrived, then you can say, good morning, I'm blah, blah, blah. I need to admit this patient in ICU because he has septic shock. Clear? We give him blah, blah, blah. Easy? Okay. Did you ask about ECG and blood results in first C? No. Did you
No.
ask about them in next C? You did not reach. Did you ask about blood gases and the X-ray in second breathing? No. So you should ask the patient oxygen saturation is not reading. Already the patient on high flow oxygen since primary assessment or first assessment, right?
Yes.
What is the next action, guys?
Look, listen, face.
Yes, what is the next action? The patient
Intubation.
oxygen saturation. Intubation.
Easier for intubation.
Yes. Please mute your mic, guys. If you are using more than one phone, please mute your mic. Okay. So here, and I think no need to use more than one phone. So this patient in breathing, Nagla, you found him oxygen saturation not responding or deteriorating. You should ask about blood gases. Clear?
Yes.
So oxygen saturation is not reading. Look, listen, and feel. Any signs of life? Yes. Then you can verbalize. What about blood gases? The blood gas showing blah 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 blah. So for sure, respiratory failure type 2. Okay. Any patient, his oxygen saturation is not responding, for sure, respiratory failure type 2, without seeing the blood gas. Okay. So you will find acidosis. You will find CO2 is high. You will find pH is low. Then BaCO2 high, then oxygen saturation is low, BaO2, okay, less than 8. It means respiratory failure type 2. Then you should say, call anesthetist, this patient needs intubation. The examiner is silent. It means the patient intubated. If you say, call anesthetist, this patient needs intubation. The examiner is silent. It means this patient is
Intubated.
intubated. It means you should confirm intubation. How to confirm intubation, guys?
Connect to Ambobag, check 4 points for
Yes,
successful.
excellent. So you will say patient intubated, connected to AMBOBAG, give ventilation every 6 seconds. In adult, every 6 seconds. In pediatric, every 3 seconds. Okay, then check the 4 points. Number 1, bilateral chest rise. Number 2, bilateral auscultation. Number 3, ETCO2. Number 4, SpO2. If all normal, it means the tube is in. You should say the tube is in. Then go for circulation. Clear, Nagla?
Yes.
Unfortunately, I said the oxygen saturation is not reading, it means 0. And then you are checking the blood pressure. Is it logic?
No.
No, the patient will die. Okay.
No.
No oxygen, no heart. How the heart will work? Because of oxygen. No oxygen, the heart will not work. All organs will not work. No oxygen, no organs. Okay. Oxygen decrease, organs work will decrease. Okay. If the oxygen 50% means the brain 50%, heart 50%, all organs 50%. Clear? Okay. So I will give you 7 out of 10. 7 out of 10. Okay.
Excuse me, Dr. Hani.
Yes, please.
Sir, when we will start sepsis 6 in C or
If she
in
ask
E?
about blood gases, I give her temperature 39.5.
Yes.
Temperature doesn't mean sepsis, okay?
Okay.
Temperature and chest infection and blah blah. So all of these criteria can give you idea about suspected sepsis, but you should confirm, okay? Confirm by blood gases. She should ask me about lactate. Some blood gases including lactate, some blood gases not including lactate. But she can say, what about blood gases in second breathing or second circulation? No problem. You can ask, what about blood gases? What about blood results? Easy.
Yes.
It's not logic to ask about blood gases and the blood results in the first C, but for the purpose of the exam, no problem. You can ask because we are
Okay.
acting. Okay. So
To
if
save
you
the
ask
time.
If you ask about lactate, they will give you, for example, 4 or 5 or 6. It means sepsis. Easy?
Yes. I mean in first C.
It's up to you. First
Okay.
C, second B, second C. Okay,
Okay. Okay, sir.
well done. So if they give you the lactate high, you can say the patient has sepsis. So in first assessment, we say it could be sepsis. But when you hear the lactate is high, then you can verbalize the patient has sepsis. Start sepsis 6. Already you give him 500 cc in the first circulation. First bolus, it will be over 10 minutes. After 10 minutes, you have idea about lactate, then you can start sepsis 6. Clear?
Yes,
Sepsis 6,
clear.
it means 3 in, 3 out. 3 in, it means the fluids, oxygen,
Oxygen,
and
ceftriaxone injection,
ceftriaxone
ceftrix,
antibiotics.
2
3 out,
gram.
it means blood gases
V
already taken, and the blood culture already taken, and the
urine
urinary
catheter.
catheter already inserted in exposure. Okay? So
Okay.
any patient, you will give fluid, insert urinary catheter. Clear?
Clear, yes.
Any patient in real practice or in the exam with fluid, urinary catheter. Clear?
Yes, clear, sir.
Okay. Any patient, seizures or unconscious, urinary catheter.
Yes, sir.
Any patient is not walking, urinary catheter. Again. Okay. So this patient, you will give 3 liters over 1 hour. So how many bottles normal saline? 6 bottles. 500 cc bolus, 10 minutes. 500 cc bolus, 10 minutes. So 6 times, it means 1 hour, 60 minutes. Okay. So if the examiner said the blood pressure is still low after 3 liters, what you will do?
We'll go
Give inotropes.
vasopressor.
Noradrenaline 0.1 microgram per kilogram per minute. Okay.
Okay, sir.
So next station, Basamat.
Yes, doctor.
Okay. So this one has massive hematemesis. What is your concern?
C.
C. What is your concern?
And massive blood loss.
Okay. What is your concern? Blood transfusion.
Blood transfer.
Okay. So you will give 4 units back the RBCs in the first C. In the next C, you will give primary back. In the next C, you will give secondary back. In the next
Secondary
C,
back.
you will give secondary back. Okay. In
Yes.
call, you will call ICU team. You will call gastroenterology team, endoscopist, prepare
OR.
OR or SATR, then activate massive transfusion protocol. Okay. The patient is not responding. What does it mean?
Look, listen, and feel any sign of life.
No, I mean the patient is not responding to blood transfusion.
Massive blood loss.
Yes, what does it mean? It means the patient has internal bleeding. Internal bleeding. You have external bleeding and internal bleeding. External bleeding and internal bleeding. If the patient is not responding, it means he has continuous internal bleeding. Okay?
Yes.
Can you hear me clearly, guys?
Yes.
Yes, sir.
It means someone said voice is breaking. So I think from your side, doctor. Okay. So here regarding massive transfusion, any patient has, for example, epistaxis. He came to you, he has no bleeding, but he has hypotension. What does it mean? This
Massive.
patient lost more than 2 liters. This patient will die if you will not give him blood transfusion. Some doctor will say, the patient is lying. How is lying? He has hypotension. Okay. Some people will find the patient with hematemesis. Hematemesis. They are inserting nasogastric tube to check his lying on. Why? The patient already hypotensive. This patient will die. And unfortunately, in some hospitals, they are giving fluids. They are killing the patient. And they are giving inotropes. Inotropes, no role in bleeding. The patient has no blood. No blood. Why you are giving inotropes? Okay. Why you are giving fluids? The patient is dying. I saw some doctors, they are killing. The patient went in cardiac arrest. Okay. So try to give primary or first action first. 4 units back to RBC. You don't have, give O blood group. You don't have, give fluids if you don't have. But if you will give fluids, maximum 250. Why you will give 1 liter? Why you will give 2 liters? Fluid kills the patient. Fluid dilutes the blood. But blood transfusion stops the bleeding. Okay? So if you find the epistaxis and the patient hypotensive, this patient will die. Go quickly. Some laboratory, they have no knowledge. They will say, how much is the hemoglobin? Why you are asking about hemoglobin? No connection between hemoglobin and massive blood loss. Okay? You should say the patient is hypotensive, the patient in shock. Don't ask about hemoglobin. Even hemoglobin is normal. You should start a blood transfusion. Clear, guys, this point?
Yes. Yes.
Please save lives. Please share knowledge to all the world. Okay. Now the 11th edition of blood transfusion, they said that clearly. They said no rule of fluids. Give blood transfusion. You will give fluid only in case you don't have blood transfusion, and it will be little amount. Anyway, so if this patient not responding to blood transfusion, it means he has continuous source of internal bleeding, so you should insert balloon tamponade. Before balloon tamponade, you should intubate the patient. Clear, Basamat?
Yes.
Okay, you have 30 seconds and 6 minutes. And try to insert balloon tamponade early. I mean, if the patient is not responding to the first action, it means he has continuous source of pain. Don't wait for 2 hours to understand he has internal bleeding. Did you get my point?
Yes. Yes.
Okay. So try to intubate early.
Okay.
You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Basamat. I'm the registrar. May I know your name and grade, please? And you also. We are expecting one patient with GI bleeding. Can you prepare the equipment? Any handover from ambulance crew?
The patient has vomiting blood in the ambulance car.
Is the patient conscious?
The patient is conscious.
Is the airway patent?
The airway is not patent. The patient has vomiting and the bleeding in his mouth.
Please, nurse, open the airway, clear the airway, and apply high flow oxygen through non-diffuser mask. How about SpO2?
SpO2 is 94,
How about RR?
RR 40,
How about trachea?
central,
How about neck veins?
normal,
How about chest inspection?
normal,
Chest palpation?
normal,
Chest percussion?
normal,
Chest auscultation for
normal,
lung and heart?
normal.
So this patient is tachypneic with normal chest examination. Maybe there is too much bleeding. How about the blood pressure?
The blood pressure is not recordable.
Any sign of life?
Yes,
How about the CRP?
9,
How about the heart rate? So patient is tachycardic. How about the peripheral pulses?
weak,
So this patient is shocked with shock, tachypneic, and tachycardic. So this patient is having massive blood loss. Please nurse, activate massive transfusion protocol. Insert 2 wide bore IV cannula. Send blood for blood grouping, cross-matching, hematology, blood gases, and activate massive transfusion protocol, and activate OR and GI doctor. And please give, we have cross-match blood. Can you give 4 units O negative blood group?
why O negative?
Patient is male.
Give,
O positive, sorry, positive blood group. Patient
give
is
cross
male.
match, doctor, cross match. Same blood group.
Same blood group. 4 units, same blood group.
Okay.
How about the GCS?
Just is 15.
Any sign of lateralization?
No.
How about blood glucose?
5.
Is the pupil equal and reactive?
Yes.
Please expose all the body. Any abnormality? Is the temperature normal? So I will endorse my patient to the ICU team and the gastroenterology team. I have one patient with massive hematemesis and hemorrhagic hypotensive shock. Please prepare OR and gastroenterology team. Is the team arrived? So I will reassess my patient. Is the airway still patent?
Yes.
Is how about SpO2?
94.
How about the blood pressure?
Blood pressure is not recordable.
Look, listen, and feel any sign of life?
Yes.
How about the can we have blood result?
Yes.
How about the hemoglobin?
5.
Give 4 unit packed RBCs. How about the platelet?
20,000.
Can you give one platelet? How about the INR?
3.
Can we give 4 unit fresh frozen plasma?
Blood
And
pressure is low.
can you please prepare for intubation for this patient, because this patient may need balloon tamponade. So we will intubate the patient first, then give the balloon tamponade. And patient intubated. Can we check the 4 points for the success of intubation? Any chest rise,
Yes.
chest auscultation,
Normal.
ETCO2,
Normal.
and SpO2.
Normal.
We will insert balloon tamponade. How about the blood pressure now?
The blood pressure now is 70/30.
We have blood result.
No.
Can we give the patient secondary pack for unit pack RBC, for fresh frozen plasma, 1 platelet, and 2 cryoprecipitate? How about
Thank you. You're
PCS?
kind done. Thank you. Okay. Excellent, Basamat. You did very well. Only 1 point. Patient intubated. After intubation, what you will do? What you will do, guys, after intubation?
Connect
Confirm,
valve mask.
confirm 4 points. So
Connect back valve mask.
Back valve mask, yes, yes.
You
Valve
missed
mask.
this point, okay?
Yes, yes, yes.
If you intubate the patient, tube only, the patient will die. Clear?
Yes.
This patient is conscious or unconscious?
Unconscious.
Conscious. The patient is conscious. You
Yes.
asked me in the beginning, is the patient conscious? I said yes. You asked me
Yes.
about GSS, I said 15. So if you
Yes.
want to intubate this patient, it will be intubation without medication or intubation with medications.
With medications.
It means rapid sequence induction, right?
Yes.
So call anesthetist. This patient needs rapid sequence induction, intubation, medication given. 1 minute passed. I will intubate the patient. Then intubated, connected to back valve mask. Like that. Clear?
Yes.
Even you did not mention clearly the medication, no problem. Okay? So you can give the patient propofol. Propofol is dangerous for hypotension. So you can give ketamine, no problem. Okay? So in hypotension, propofol is contraindicated. So blood transfusion, you can give the patient ketamine and you can intubate. Easy? Okay. Again, intubation only, the patient will die. You should connect it to back valve mask, 1 ventilation every 6 seconds. Okay. I will give you 8 out of 10, okay? Okay, next one, Ali.
Yes, sir, here.
Okay. Next station, chest pain. Chest pain, what does it mean?
Circulation problem.
What does it mean, chest pain?
Maybe thrombosis,
What does it mean, chest pain?
unstable patient.
Unstable. Okay.
Yeah.
So if the patient has arrhythmia, I will consider this patient unstable. So my eyes on the monitor. Any patient with chest pain, my eyes on the monitor. Defibrillator is connected. Even I'm taking history. Yes. Any patient with chest pain connected to monitor. Number 1. Easy.
Yes.
And my eyes on the monitor. If I find tachyarrhythmia, I will give him shock. If I find bradyarrhythmia, I will give
Bradyarrhythmia.
Atropine.
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 Please prepare, guys. You should listen to previous recordings. You see, we are wasting time for 2 sessions, for 2 stations.
Okay, sir.
So the patient has chest pain. What does it mean? It's unstable. Signs of instability, shock, syncope, chest pain, myocardial ischemia in the ECG, signs of heart failure. Any patient, I am taking history, chest pain, connected to monitor, attached defibrillator. My eyes on the monitor. I'm taking data from him, my eyes on the monitor. Once I'm preparing the nurse beside me. I'm telling here, once I find the VT or VF, I will give him the patient shock. So VT, the patient is alive. VF, the patient is arrest. Okay.
Okay, sir.
So anyway, this patient, if they show you ECG like that, you can verbalize the ECG is showing
So
STEMI,
STEMI, yes.
where it's not a big issue. If you are familiar with the ECG, mention. If you are not familiar with the ECG, no problem, just say STEMI. So
Okay.
anterolateral MR, activate cath lab,
Cath lab,
call ICU
cardiologist,
team, cardiologist,
just okay.
ICU
You will
team, and the cardiologist team first. Okay. Then you will go for giving the patient the treatment. If the patient is conscious, you will give him
aspirin 300 milligram.
Belafix, aspirin Belafix. In circulation, and if the patient is conscious, you can give him nitroglycerin and morphine if no contraindication. What does it mean, no contraindication? No hypotension, no bradypnea. So you will give in circulation. If you find circulation normal and RR normal, you can give nitroglycerin and morphine. So he went to give nitroglycerin morphine
In circulation.
circulation. He went to give aspirin Belafix in airway
Okay, sir.
if the patient is conscious. Okay.
Okay.
So at any time the patient has arrhythmia, VT, you will give this a shock. Synchronized 120, then 130, then
100,
150.
150, yes.
If the patient is unconscious, you will give if the patient is in cardiac arrest, you will give unsynchronized.
Synchronized.
It will be 200 joules.
Biphasic, yes, sir.
Then the second shock, 200. The third shock, 200. Okay?
Yes, sir.
Then
Yes.
amiodarone. Okay.
Okay,
So
sir.
you have 30 seconds and 6 minutes. So if the patient has chest pain, they did not show you ECG, you should do CPR if the cardiac arrest, and no need to activate cath lab because we have no evidence for cath lab. Okay?
Yes, sir.
So
No STEMI.
no ECG. If the
Yes.
patient has no ECG, no
Yes.
need to activate cath lab. Okay?
Okay.
So what if the patient has cardiac arrest? Okay? Then you will give thrombolysis. So you can say the patient in cardiac arrest, do blah, 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 blah. Then I will consider for H40s, the most likely problem is
This is thrombosis.
thrombosis, T, toxin thrombosis. T, thrombosis. Okay?
Yes.
Well done. So you will give alteplase. 50 milligram, 50 milligram. Okay?
Okay, bolus answer.
Bolus, yes.
Yes.
And you can repeat 50 if the examiner said 15 minutes passed. You should understand you will give another 50.
Okay.
If he did
And
not
then,
mention 15 minutes passed, he said 2 minutes passed. Okay.
yes.
Then if he has signs of life, you can give 50, but infusion.
Okay, sir.
It will be in circulation. So after cardiac arrest, you should start by A. So A, B, C, D, E. Clear?
Yes, sir.
For example, the patient has cardiac arrest in C, in circulation, or in D, disability. Then you can, after ROSC, you can say, excellent guys, the patient has ROSC. Then I need to hand over this patient to blah, blah, blah. I will reassess the patient. What about airway? What about breathing? And so on. Clear?
Okay, clear.
Okay. So you have 30 seconds and 6
Sir,
minutes.
can I ask one question?
Okay. Why you are not asking guys in the group?
Yeah, I asked in the group, sir.
I will see. Okay.
Sir,
Yes, please.
regarding this patient, if he is having, like I asked in the group, not sustained VT and intermittently is going into VT, but cath lab is not available for 30 minutes. This case was got my friend got this case.
Okay.
So he was going into unsustained VT, but conscious drowsy. and cath lab was not available, cardiologist not available for next 30 to 60 minutes, and they cannot shift to other hospital.
Okay, so I understand the patient is conscious
Yes.
and he has VT.
Yes, VT, non-sustained, sir.
I don't care. He has VT.
Yes, sir.
Sustained or not sustained, he has VT. Okay. Stable or unstable?
Patient vital stable, sir.
You said chest pain.
Yeah, chest pain unstable.
So unstable. He needs a shock. Patient is
Got it.
alive,
Yes.
unstable. So this is shock. So
Non-sustained.
No,
Thrombolysis.
because they didn't allow him to give him shock because it was just for 2 seconds and then normal sinus rhythm was coming. Cardiac rhythm.
you can see on the monitor. You can see on the monitor VT.
Yes. Yeah, VT, which was like for 2 seconds and then the normal rhythm.
So if you have VT on the monitor, and once you recharge this shock, you did not find the VT, do you think you will give shock?
No.
Of course not. You will give shock if the rhythm on the monitor VT, 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 VT. Did you get my point?
Yeah.
If VT is in sinus rhythm, VT is in sinus rhythm, you cannot give shock because once you recharge this shock and you will give shock, you will find the sinus rhythm. Of course, you will not give. Did you get my point?
Yes.
You will give this shock only if you find the monitor VT continuous. Clear?
Yes. No, my doubt is whether we have to thrombolize the patient because cath lab is not available.
If the
for
cath lab is not available now, you should confirm not available in the hospital or not available now. It's a difference. Okay. So if the cath lab is not available in the hospital, and you should ask when the any near cath lab, for example, maybe close to this hospital, less than 120 minutes. Okay. So if less than 120 minutes, don't give thrombolysis. If more than 120 minutes, you can give thrombolysis. Clear?
Yeah, cath lab was there, sir, available, but not free because they are doing continuous angiogram. So we can thrombolize and
Yes,
then do
doctor.
rescue
I'm
QT
I'm
state.
clear. I'm clear. I
Okay,
said
sir.
if not available in the hospital at all, not applicable, or not available within 120 minutes, you can give thrombolysis.
Okay,
Clear?
sir.
So
Right.
you should ask the examiner like that. When the cath lab will be available, done. Whatever in the same hospital, you can tell him like that. Whatever in the same hospital or different hospital. If he said within 120 minutes, don't give thrombolysis. If more than 120 minutes, whether in the same hospital or different hospital, you should give thrombolysis. Clear?
Yes, sir.
Okay. Ali?
I will start, sir.
Yes, please.
Okay. Hello, I'm Dr. Ali, team leader today. May I know your name and level? Nice to meet you. Are you a ALS provider? Can you take care of circulation? I need another nurse to take care of airway.
Patient arrived.
Any handover of the ambulance crew?
Yes, this patient, he has severe chest pain and this is ECG, doctor.
Okay, thank you. This ECG shows STEMI. So please, STEMI. So please give the patient. Okay, is the patient conscious?
The patient is conscious.
Is the airway patent?
The airway is patent.
Okay, thank you. Please give the patient 300 milligram aspirin orally and Plavix 300 milligram and apply high flow oxygen. Please expose chest and attach monitors. What is the SpO2?
You will not activate cath lab?
Sorry, also please activate the cath lab. Patient maybe need urgent stent insertion. Please, can you connect the monitor and what is the SpO2?
SpO2 normal?
What about the RR?
Normal?
What about the neck vein?
Normal?
Trachea?
Normal?
Inspection of the chest?
Normal?
Palpation?
Normal?
Percussion?
Normal?
Auscultation of the lung and hearts?
Normal?
Okay, thank you. I need to assess the circulation. What is the blood pressure?
Normal?
What about the CRT?
Normal?
What about the peripheral pulse?
Normal?
What about the what about the heart rate and monitor? Oh, I can see this patient in VT and the patient has severe chest pain, so it is unstable VT. Please call ICU team and cardiologist and insert to IV cannula, take blood for hematology chemistry, including heart function, VBG, toxicology, and blood culture. And we will give, a patient is conscious, we'll give him sedation, give him 4 milligram midazolam IV, and we will give him synchronized DC shock, 100 joule, 120 joule. Okay, given. I will check the disability now. What about the GCS?
Sedated,
Okay, sedated. What about the pupils?
equal reactive,
Any signs of lateralization?
normal,
Blood sugar?
normal,
Expose all body. Any other abnormality?
normal.
Okay, what is temperature? Okay, I need to hand over this patient to ICU team and cardiologist. Meanwhile, I will assess the patient. What about, is the airway still patent?
Patent,
SpO2,
normal,
blood pressure, and heart monitor.
normal.
Okay, okay, I can heart monitor. I can see the patient still in unstable VT. A patient is sedated. We will give him another synchronized DC shock. We'll go to 130 joule now, given. Okay. We'll reassess the patient again. We'll hand over the patient to the ICU team. And are they here? Okay, we'll reassess the patient. What about the airway? Is beaten? Still beaten?
Yes,
SpO2?
normal,
Okay. Blood pressure?
normal,
Heart monitor, I can see the patient is still in VT. Okay, unstable VT, and patient already sedated. We'll give him third shock, synchronized shock. We'll give him 150 joule. Please activate, I mean, we informed the cath lab, and we'll give the patient, also we'll give the patient nitroglycerin if the blood pressure is normal, and also we'll give the patient morphine if he has been. What is the blood pressure?
normal,
Okay, we already given 3 shock of synchronized. We will give him the patient amiodarone now, 300 milligram IV over 10 minutes. 10 minutes passed. What about the blood pressure?
the patient is unresponding.
Look, listen, fear for any signs of life.
No,
Okay, this patient in cardiac arrest. Please call cardiologist and SU team and start high quality CPR 30 to 2. Okay, I can see the patient in VT, pulseless VT. So please, this is shock rhythm. We will give the patient now unsynchronized shock. Already patients, okay. We will give him now 200 joule. 200 joule unsynchronized shock, and start high quality CPR for 2 minutes. The most likely cause of cardiac arrest is thrombosis. So please, and continue high quality CPR for 2 minutes. Okay. We will give the patient now alteplase 50 milligram bolus, 50 milligram bolus alteplase. Okay, 2 minutes pass. Okay, I can see the patient still in VT, but any signs of life?
no,
Okay, the patient still in pulseless VT. We'll give it another synchronized DC shock 200 joule and continue high quality CPR for 2 minutes, and we will intubate the patient now. So 2 minutes pass. Any signs of life?
no,
Okay, this is the third. This patient still in pulseless VT. Okay, we'll give him the third shock unsynchronized, and continue high quality CPR for 2 minutes. Okay, patient intubated. We will recheck the correction of the intubation by ambu-bag valve mask and give one ventilation every 6 seconds, and check for successful 4 points. So 2 minutes pass. Any signs of life?
no,
Okay, the patient is now third shock. We will give now 1 milligram adrenaline IV and plus amiodarone 300 milligram IV bolus. Okay, and continue high quality CPR for 2 minutes. Okay, 2 minutes passed. Any signs of life? Okay, excellent, guy. Okay, we have
yes,
sinus rhythm.
yes.
And
The
okay,
patient has
thank
signs
you,
of life.
thank you,
Okay,
guys.
thank you, doctor. Thank you.
Thank you, sir.
Okay, your turn done. So you did very well. I will give you 10 out of 10. Thank you.
Thank, Thank you, sir.
So please activate cath lab once you see ECG STEMI. So once the ambulance crew show you this ECG or the nurse or the examiner, then you can verbalize activate cath lab and the STEMI alert, okay?
Okay, sir.
So here, number one, because already you have evidence of STEMI. So what is the decision? Cath lab. Whatever you will do to the patient, no benefit. Clear?
Yes, sir.
Cath lab will remove the blood clot. Okay? Okay. So you will give aspirin Belavix, excellent, and you will give morphine nitroglycerin. Did you give morphine nitroglycerin?
Yes, in circulation, sir.
Okay. This patient, in the end, if the patient has sinus rhythm, then excellent, guys. The patient has sinus rhythm. What you will do after ROSC in
Where is the ABCD again?
yes, ABCDE. The most important here, ECG and the blood pressure. Easy.
Yes.
Any cardiac arrest, but of course you should go for A, B, C. Okay, you give the patient high flow oxygen in the beginning. No, don't give high flow oxygen in chest pain. Okay,
Yes, sir. Yes, I forgot
don't
this one.
give high flow oxygen. So in chest pain, you will ask about breathing, the 8 points. After the 8 points, if you find the saturation normal, ignore oxygen. Okay.
Okay.
Okay. So this one, what about airway? The patient intubated, sedated. Okay. And then you will go for breathing. In breathing, you will ask about the 8 points again. Then circulation, you will ask about the 4 points. Then you will do ECG for the patient. Okay. Well done.
Thank you,
What
sir.
if you find the patient is hypotensive? What you will do?
Hypotensive, I will give inotropes.
So you
I
can,
mean, vasopressors, sorry, sir. Vasopressors, norepinephrine.
so you will give first fluids. Fluids. What is the cause of shock here?
Cardiogenic shock.
Not all cardiac arrest cardiogenic shock, but because of STEMI could be cardiogenic shock. Clear?
It could be, yes.
So any cardiac arrest followed by ROSC followed by hypotension doesn't mean cardiogenic. Okay. So
Yes, sir.
if the likely cause is T thrombosis, so it could be cardiogenic shock. Here you should give 250 ml normal side, 250 more than enough. Okay.
Okay.
Then later you can assess if still hypotensive, you can give whatever noradrenaline or dopamine or anything like that. Okay.
Okay, sir.
Thank you. Next one,
Thank-
Ahmed Mohammed.
Yes, Dr.
Regarding the 21 and the 25, almost the same information, same guidelines. So don't worry. This station is anaphylaxis. The patient has rash. Rash, it could be anaphylaxis, yes. What is the definition of anaphylaxis? So sudden acute. Okay? It means patient has problem 5 minutes ago, for example, or 10 minutes ago. Any problem? No. Any problem in airway, like hoarseness or stridor or swelling in the tongue or lips. What else? Breathing, like hypoxia or wheezes or tachypnea or anything like that. Okay. In circulation, like peripheral pulse is weak or CRT high or blood pressure is low or exposure rash. If you find any of these findings and it happened 5 minutes or 10 minutes ago, what is the diagnosis?
Anaphylaxis.
Anaphylaxis.
Anaphylaxis. Okay. So what is the action? Number one, adrenaline IM. In the second assessment, I said in the first assessment, 1 dose IM adrenaline. First assessment, I mean in airway, breathing, circulation. One dose enough for all. Okay. So if you give adrenaline for airway and you find the breathing wheezes, you will give adrenaline again?
No.
No. So one dose adrenaline enough for airway, breathing, circulation, disability, exposure. Then you reassess the patient again after 5 minutes. You find same problem or different problem, you will give second dose IM adrenaline. Then you will assess after 5 minutes, the third assessment. If you find the same problem or different problem for anaphylaxis, you will give the third dose of adrenaline. It will be
IV.
IV infusion. So you should
Oh,
verbalize the patient has refractory anaphylaxis. Then call ICU team and anesthetist. The patient needs IV adrenaline infusion. How to give that? It will be 1 milligram adrenaline over 100 cc normal saline over 1 hour. It means you will reassess the patient after
1 hour.
1 hour. You will say after 1 hour, it's too long. Yes, if you find the patient, you are infusing adrenaline. You are infusing adrenaline within 1 hour. If you find the patient is not responding within the 1 hour, what you will do? Nothing. Because the patient already on infusion, right?
Yes.
If the patient has a stridor or hoarseness of voice or anything within the 1 hour, nothing to do. Already he's on infusion. But you should observe if he has no signs of life, if he has any serious problem like that, you should take action. But I'm talking about the patient is still alive. Okay. Then after 1 hour, you will reassess the patient. You find the patient has airway problem. You will give
Nebulizer.
which nebulizer?
Adrenaline for airway.
Adrenaline nebulization. It will be 0.5 ml per kilogram, maximum 5 ml. It means for airway problem. So you will give nebulization in the fourth assessment. Easy?
Yes.
If the patient in the fourth assessment has wheezes, what you will give?
Salbutamol nebulizer.
If the patient already on nebulization, you will give after adrenaline nebulization. Clear?
Yes.
For example, you find the patient has airway problem, then give nebulization adrenaline. Then go for B, breathing. You find the wheezes, so you can tell the nurse, give salbutamol nebulization after adrenaline nebulization. Easy?
Yes.
So any nebulization in which assessment?
Fourth.
Fourth assessment. Easy? So you will give first dose adrenaline IM in the anterolateral midpoint of the right side. Then after 5 minutes, you will give adrenaline IM 0.5 milligram in the anterolateral midpoint in the left side. Okay?
Yes.
Okay. So you have 30 seconds and 6 minutes.
Can I start?
Yes, you can.
Good morning. I am Dr. Ahmed, ED Registrar, team leader today. May I know your name and level, please? We are suspecting patient came with the rashes after he was in the restaurant.
Patient arrived.
From the ambulance crew?
The patient was eating in Chinese restaurant and suddenly he collapsed.
Okay. Is the patient conscious?
The patient is conscious now.
What about airway? Patent?
The airway not patent. The patient has a stridor, hoarseness of voice.
Okay, this patient was in the restaurant eating, has hoarseness of voice. It could be anaphylaxis. Please, we need to call anesthetist, call ICU to you and anesthetist. And this patient need intubation. I will give adrenaline 0.1 milligram in right thigh, midpoint lateral thigh. And I will give high flow oxygen non-rebreathing mask. And I will go for breathing. What about SpO2?
SpO2 is 9.4.
Respiratory rate,
Normal.
trachea,
Central.
neck vein,
Normal.
inspection of the chest,
Normal.
palpation,
Normal.
percussion,
Normal.
auscultation of the lung and heart.
Wheezes.
Okay, already we give a first dose of adrenaline, so we'll go for C. What about blood pressure?
Blood pressure is not recordable.
Any sign of life?
Yes.
What about CRT?
Normal.
Peripheral pulse,
Weak.
heart rate and rhythm? Okay, I can see in the monitor VT. Patient is conscious. It's shockable rhythm. Is the patient conscious? I will call the ICU team and cardiologist, and I will give we can give amiodarone 300 milligram IV. What about Glasgow Coma Scale?
How much is the blood pressure?
Blood pressure was low,
Blood pressure was not recordable.
not okay. We have blood pressure recordable. We will give this. We have shockable rhythm. Please call cardiologist and give DC shock 120 joule. What about the rhythm? Same. Any pulse? We'll
Yes.
give another shock. Another shock 130 joule. Shock deliver. Any sign of life?
Yes.
Any pulse? There is pulse.
Yes.
Okay. We'll give third DC shock. Synchronize DC shock 150 joule. What about the rhythm? Now rhythm to sinus. What about the pulse?
Yes.
There is pulse.
Yes.
Go. So I will go for disability. What about the Glasgow Coma Scale?
Just as
Before we go, we'll insert to IV cannula, extract blood for hematology, biochemistry, blood gases, blood culture, and toxicology, and we'll start with IV fluid 500 ml bolus. And already we gave first dose of adrenaline. What about the Glasgow Coma Scale?
just as you should sedate. So I will consider sedated. You did not sedate.
Yes, well, the patient was conscious. We should sedate the patient before we give sedation. Pupils,
Equal reactive.
any sign of lateralization?
No.
Blood sugar,
Blood sugar is normal.
exposure, all body, any other abnormality? What is the temperature?
Normal.
I will hand off the patient to ICU team, and I will reassess the patient. What about is the patient conscious or sedation?
You should say the patient already sedated.
Or is it sedation? Is the airway is patent?
The airway is not patent. Okay, your time done. Thank you. Okay, thank you, Ahmed. So, in the beginning, introduction done, handover from ambulance crew, then You did airway. You found the patient has hoarseness of voice stridor, so you diagnose the anaphylaxis. You called the ICU team and the anesthetist. You gave the patient high flow oxygen. You can say this patient needs early intubation. So what you will do with the airway? Oropharyngeal, nasopharyngeal. Did you insert oropharyngeal, nasopharyngeal?
No, I didn't.
You should insert, okay?
Yeah.
So you are planning for advanced airway, you should start basic airway. Easy?
Mm-hmm.
So you should insert oropharyngeal, nasopharyngeal, and then high flow oxygen. Okay. If the patient is not tolerating oropharyngeal, it's not our issue. If the examiner is silent, it means done, no problem. If he said not tolerating, remove. Okay. So you will go for breathing. You find the wheezes, no need to give because already done in airway. Then circulation, I said blood pressure is not recordable. Look, listen, and feel in signs of life. Yes. What you will do here, you found the patient has unrecordable blood pressure and you find VT. So once you found VT, I found you are distracted. No need. Okay. What is the problem if the patient has arrhythmia? Don't worry. Take your time. So you can verbalize the patient has unstable VT and shock. What is the type of shock here?
Hypoxia, hypovolemia.
What is the type of shock? What is the type of shock? Anaphylactic shock. Ask yourself, is it cardiogenic? No. No heart problem. Is it septic? No sepsis here. Is it obstructive, like pulmonary embolism or tension pneumothorax? No. Is it cardiac tamponade? I mean obstructive? No. So anaphylactic, right?
Yes.
So the patient has anaphylactic shock. You should verbalize like that before call. So verbalize findings, then diagnosis, then call, then intervention. Easy?
Yes.
You should verbalize the patient has unstable VT. He has shock. It could be anaphylactic. Call ICU team, cardiologist, anesthetist. This patient needs a DC shock, needs a conscious sedation. Give midazolam and fentanyl, or you can say give the patient propofol here, not suitable, right?
Yes.
The patient will die if you give propofol in hypotension. The patient will die. So you can give midazolam fentanyl. Okay. You should give fluids before midazolam. The patient has unrecordable blood pressure. Did you give fluids? No.
Yes, I gave.
You give later, after the patient died. So you should give early. Okay. Any patient, you will do sedation. Again, guys, for real practice or in the exam. Any patient, you will give sedation, even his blood pressure normal. Give fluids. Give oxygen. Easy. Again, any patient, you are planning to give sedation, give two important treatments, fluids and oxygen. Even his oxygen normal? Yes. Even his blood pressure normal? Yes. Clear? To decrease side effects. This is called pre-treatment. Pre-treatment. Okay. So you should give 500 cc normal saline. You will give DC shock, already sedated. You will give DC shock, synchronized 120s and 130s and 150. Then amiodarone if not responding. Okay. The patient already returned to sinus rhythm. Then you will continue. At any time you will find in the second assessment any problem, then what you will do, you will give the second dose of adrenaline and continue the same approach. I will give you 7 out of 10. Thank you. Next one, Nagla.
Yes. Assalamualaikum.
Alaikum assalam. CKD. If you find chronic kidney disease in the scenario, think about hyperkalemia. So this patient missed the dialysis, you will arrange for dialysis and the nephrologist in the end of the station, and you should prepare that in the beginning at any time you discover that. Okay, so this patient may be conscious, may be unconscious, may be alive, may be cardiac arrest. The examiner can give you any possibility. Clear?
Yeah, clear.
Okay. So if the patient unconscious in the beginning and unresponsive and he has cardiac arrest in the beginning, it means nothing done for the patient. Nothing. So in the first cycle, take your time to do everything. Take your time to verbalize everything. Clear?
Okay.
Because in the first cycle, you will attach monitor, you will expose the chest, attach a monitor, you will insert it to IV access, you will start the high quality CPR, you will attach a back valve mask, okay? You will verbalize the 4H4Ts, you should verbalize the most likely problem, you should give the treatment. Do you think the patient will return to ROSC without reversing the cause?
No.
So don't ask about 2 minutes bus until you verbalize everything. So here, for example, hyperkalemia. So you will ask about blood result, blood gases, okay? And if they give you blood results or blood gases, potassium is 10, you will verbalize this is the cause of cardiac arrest. Then reverse. Can you see? I did not ask about 2 minutes yet. You should ask about the monitor. How you will reverse? Maybe the patient needs a shock. He will not return without shock. Maybe the patient has sinus rhythm. He will not return without adrenaline. So don't ask about 2 minutes until you verbalized everything. Clear?
Okay.
In the next cycle, nothing to do because already you did everything in the previous cycle. So in the next cycle, it will be very quick. Okay?
We'll start A, B, C, D.
I'm talking about cycle. Cycle means the cardiac arrest. Cardiac arrest, it means forget ABCDE. No ABCD in cardiac arrest.
Yeah. Okay.
So you have two possibilities, alive or cardiac arrest. Alive, ABCDE. Cardiac arrest, it means the CPR and the ventilation. No ABCDE.
Okay.
Don't ask about oxygen in cardiac arrest. Don't ask about blood pressure in cardiac arrest. Don't ask about anything relevant to ABCDE in cardiac arrest. Okay?
Okay.
So you have 30 seconds, then 6. So here, what is the treatment for hyperkalemia?
Calcium chloride, 10 ml, 10% IV, sodium bicarbonate, 50 ml, and insulin dextrose, 10 unit, 10%.
And what else?
Salbutamol inhaler.
But in cardiac arrest, not
In
applicable.
patient is conscious, yeah.
Okay. You have 30 seconds and 6 minutes.
Okay, hello. We'll start.
Start, please.
Hello, my name is Dr. Najla. I'm ED registrar. May I confirm your name and level, please? Nice to meet both of you. We are receiving one patient who have collapsed at home. He has a history of kidney disease. Let's prepare the airway and circulation equipment and waiting for the patient. Wear our PPE, okay? Patient arrived.
Patient arrived.
Any endorsement from ambulance crew?
The patient is collapsed.
Okay. I will go to my patient. Hello, sir. Is my patient speaking?
Patient is unresponding.
Look, listen, and feel. Any signs of life? There's any pulse?
No signs of life.
No signs of life, no pulse. So this is cardiac arrest. Please, team, can you activate adult life support and call Resus team and attach, please, the defibrillator. Start high quality CPR in a rate of 30 to 2 and take care of ambu bagging, one breath every 6 seconds. And I wanted to please to put 2 IV lines and extract blood for hematology, biochemistry, and VBG. And when the defibrillator is attached, can you show me the rhythm, please?
This is the ECG from ambulance crew.
The ECG, okay. Okay, now the rhythm shows that the patient have VTAC and there is no pulse, so it's a shockable rhythm. Let's prepare for the first shock, please. The first shock will be 150 and continue the CPR till I prepare for the shock. Now I'm preparing for the shock. I'm clear, everybody's clear. Remove the ambu bagging, shock delivered. Resume high quality CPR in the rate of 30 to 2 and take care of ambu bagging, and let's revise the 4Hs and 4Ts. For the hypoxia, the patient is now in the oxygen ambu bagging, and for the hyperkalemia, any result from the any blood result yet?
What do you need?
I want to check for the potassium level because this patient is have a kidney disease.
The potassium is 10 millimole.
The potassium is high, and I think the ECG a while ago shows also a peak T wave. So this patient, the cause of his arrest most probably is hyperkalemia. So I want you to give I wanted to give calcium chloride, please, 10 ml 10% IV, and sodium bicarb 50 ml IV, 8.4%, and we will insert the urine catheter later. And I want to give also insulin dextrose 10 unit 10%. And what about CPR? Are you continuing doing the high quality CPR? Okay. The patient is still have any pulse?
No.
Okay, continue high quality CPR in a rate of 30 to 2, and I will give the second shock. I will give this time 200, and I'm giving the shock, preparing for the shock. I'm clear, everybody's clear. Take the ambu bag. I'm delivering the shock. Resume shift, please, and resume the high quality CPR in a rate of 30 to 2, and take care of the ambu bagging. Now for this patient, we gave the reversible cause, and we extracted blood. We are resuming CPR with high quality. We are giving this any 2 minutes pause, please. We'll check the rhythm again. Okay. Any pulse?
No.
Okay, I will give the third shock. This time I will give 250, and I will. I'm clear. Everybody's clear. Remove the ambu bagging. Shock delivered. Resume high quality CPR. I'm considering to give amidaron for this adrenaline for this patient, about 1 milligram, 1 to 10,000, and we will repeat every alternative cycle like 5 minutes, and we will give also amidaron 300 milligram IV, and continue the high quality CPR. We want the CPR to be continuous for this patient. Now I think the rhythm is changed. Any pulse, please?
Yes.
Okay, thank you, team. We achieved ROSC for our patient. Thank you very much. And we are going to check now for the airway for the patient. The patient need to be intubated, and call anesthesia, please. And I want you to call also the nephro and prepare for the dialysis. Maybe the cause is hyperkalemia for missed dialysis. And for hypovolemia, can we put also fluid, 500 ml? And for
Thank you.
hypothermia.
Thank you. Your time done. Okay, excellent, Nagla. So this patient, in the first, he is unresponsive. You discovered he has no signs of life, so cardiac arrest. So activate cardiac arrest call. Did you activate cardiac arrest call?
Yes, activate adult
Okay.
life support.
Okay.
And I call for resystem.
Yes, you did well in the first cycle. You did everything. You should correct the 4H40s. Done. The patient already received three unsynchronized DC shock, 200, 200, 200. Then, of course, after each shock, resume high quality 2 minute CPR. Well done. Um, did you intubate this patient in cardiac arrest? It's not mandatory to intubate, but I'm
I
asking.
to intubate at last that I consider intubation after the ROSC. This patient considered for
Okay,
intubation.
so this is mistake. If
Okay.
you intubate the patient in cardiac arrest, this is your right. But if you did not intubate, it's not mandatory to intubate the patient after ROSC.
Did that. Okay. So I will
Maybe the
intubate at
patient is maybe the patient is conscious, alert after ROSC.
okay.
I got many patients, they have ROSC and they are alert after ROSC.
So I'll
So
intubate at the time of arrest. Okay.
if you intubate, if for example, this patient, his destiny to be awake after ROSC, and unfortunately you intubated during a cardiac arrest, no problem. But
Okay.
if you intubated in cardiac arrest, then after ROSC you can say the patient, what about airway? Answer yourself. The patient already intubated. Easy.
Mm.
If you did not intubate, ask, is the patient conscious? If the examiner said the patient is unconscious, okay, ask about the GSS and then you can intubate if less than 8. Clear?
Okay. Okay. That's good.
Like that.
Yeah.
If the patient is conscious, okay, good. Keep on high flow oxygen. So you
Okay.
will ask two questions. Is the airway patent? So is the patient conscious? Is the airway patent? Same,
Okay.
like constellation. Then breathing. Ask again about breathing. What about SpO2 or art, retianic veins, inspection, palpation, percussion, auscultation? You did not ask in breathing like that, okay?
Mm.
You are dealing as routine. You will give the patient blah, 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 blah as routine. No, you should correct the abnormalities after ROSC. What
Okay.
if everything normal after ROSC? You will give the patient treatment? No. Clear?
No. Yeah.
So if the patient is hypertensive, you will give fluids? No.
No.
You will give vasopressors? No. So it's not routine.
Mm.
So you should assess. So assessment as usual.
Assessment of ROSC. Okay.
Assessment, findings, call, intervention. You received the patient in cardiac arrest. You did not do assessment. So when you found ROSC, it means you will start the first assessment because you did not assess before.
Okay. So reassess.
So
Okay.
for you, this is the first assessment. If you did first assessment in different station, A, B, C, D, E, then the patient has cardiac arrest. After cardiac arrest, you can do second assessment. Easy?
Yes. Okay.
Like that.
Easy. Yeah.
Okay. Did I give you the marks?
No. No.
Okay, so I will give you 9 out of 10. You're perfect. Thank you.
Okay. Thank you.
Next one, Muzammil.
Yes, sir.
Okay, so if VT and you are not sure what to do, give amiodarone. Easy?
Yes, sir.
I'm talking in general, in real practice. VT, you are not sure, you will give shock or not. What you will do?
Give amiodarone.
You are not sure, is it SVT or VT? What you will do?
Give amiodarone.
Amiodarone. Easy?
The 300 mg complete full.
300 milligram over 10 minutes.
Okay.
Okay. Did we miss any station? No. Okay. So this is station for overdose. Sometimes they will say overdose. They will give you surprise inside the room. No problem. So they will give you the most common stations. Maybe TCA, maybe opiate, maybe huh?
Beta block.
antihypertensive drugs like calcium channel blocker or beta blocker, right? Or maybe your junior doctor was doing sutures and the patient collapsed, lidocaine toxicity. Clear?
Yes, sir. Yes, sir.
So if they give you ECG like that, what is the problem?
TCA toxicity.
TCA toxicity. Maybe in breathing or in airway, the junior doctor or the nurse show you tablets of amitriptyline, or maybe they will verbalize amitriptyline by name. What is the problem?
TCA toxicity.
So TCA toxicity, okay?
Yes,
If
sir.
they show you blood gases, what is the problem?
Metabolic acidosis.
Yes. So your eyes on pH and bicarb. Easy?
Yes, sir.
So if the actor asks you, what is this amitriptyline TCA toxicity? No need to talk too much. What is this? TCA toxicity. Antidepressant. Done. He asks you how this affects the patient. What is your answer?
It can cause arrhythmias.
Number one, brain. Number two, heart. Any toxin like that, any overdose like that. Number one.
Brain excitation.
Number two, heart.
Heart.
So brain up or down. What does it mean up or down? Excitation or depression. Heart up or down. It means tachy or bradyarrhythmia. Easy.
Yes, sir.
So if anyone, any doctor, ask you how this affects the patient, any toxin, you will say brain excitation, CNS excitation, CNS depression, heart tachyarrhythmia or bradyarrhythmia. Easy.
Yes, sir.
Don't talk too much. Done. CNS depression or excitation, heart arrhythmia. Done. Okay. Then he asks you, what about this ECG, TCA toxicity? Verbalize the finding very quickly. So you will say dominant R wave in AVR. Done. Sinus tachycardia. Done. What else? First degree AV block. Can you see the B starting B and the T one wave? So starting from here up to here. So more than one large square. So BR interval prolonged. So it means the first degree AV block. First degree AV block, it means arrhythmia also. Okay. White QRS, very white QRS. Okay. So if they show you blood gases, what is this? You can say metabolic acidosis. Done. No need to comment on anything. Killer
Sir,
Muzamil?
sir, one thing. If in ECG we are unable to figure out whether it is TCA toxicity, like in the examination presence, we may get some blackout. So if we don't discover
They will give you amitriptyline for sure.
okay,
In previous exams, they have box of amitriptyline tablets. Okay?
okay, sir.
Or maybe they will say the patient has depression. Okay?
Okay, sir. Right.
So for sure, if you did not find opiate, it means a triad. It means the patient has pinpoint pupil, the patient has RR bradypnea, the patient has CNS depression, GSS is low. Is it opiate? No. Is it beta blocker? The patient has bradycardia? No. Is it hyperkalemia? Did they mention CKD? No. They said overdose. So TCA, easy.
Yes, sir.
By exclusion, rule out. Okay?
Yes, sir.
So if you are not sure about the ECG, no worries. Ask yourself, they mention overdose in the scenario. So is it opiate? No. Opiate, it will be bradycardia. Brady. Beta blocker or calcium channel blocker, bradycardia. Clear?
Yes.
Okay. So you have, what about the treatment? The treatment is number one, fluids. What is number one?
Fluid.
Number two, sodium bicarb. Number three, magnesium sulfate. Number four, intralipids. Okay, all of them IV. So number one, fluids 500 cc bolus. Number two, you will give sodium bicarb 8.4%. It will be 50 ml. Okay. If the patient has arrhythmia, it will be 100 ml. Clear? If the patient has cardiac arrest, 100 ml. So arrhythmia or Cardiac arrest, 100 ml. What if you already give 50 ml for this ECG? Then the patient got cardiac arrest. You have two options. Either to add further 50 ml or to give further 100 ml. Clear, Muzammil?
Yes, sir.
Okay. What if the patient has unstable VT? You will give first DC shock, synchronized, 120, then 130, then 150. Still not responding, don't give amiodarone, contraindicated. Clear?
Yes, sir.
No need to give amiodarone and don't give lidocaine, no need. Okay?
Yes, yes, sir.
Okay. So regarding if the patient has a stable VT, stable. So this patient has VT and he's conscious, vital signs are normal. What you will do?
Sir, we can wait.
Fluids.
Fluids, yeah.
Number one, we said fluids. Number two.
Soda bicarb.
Number three.
Magnesium.
Number four. Intralipid.
Intralipid if patient collapse.
Okay. Already the patient is collapsed. Collapse, it means the CNS or heart.
Yes, sir.
The patient has VT, it means intralipid. Easy?
Yes.
Any problem in the patient? Intralipid. Okay. So you give the treatment and the patient is not responding. Same VT. What you will do? Is stable and you give fluids, you give blah 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 blah. Still VT. What you will do?
We can give shock now, sir.
Shock. Excellent. So in general, right hand, left hand. Right hand pharmacological, left hand electrical. If pharmacological failed, you will go
Electrical.
electrical shock. If electrical shock failed, you will go for
Pharmacological.
yes. This general rule, easy
Yes, sir.
in any arrhythmia. If the patient is stable, you will start by
Pharmacology.
pharmacological cardioversion. Okay. If failed, you will go for electrical cardioversion. If the patient is unstable, you will go for
Electrical.
electrical cardioversion. If failed, you will go for pharmacological cardioversion. Okay. So I will emphasize on the dose now and the rule. So fluids, 500 cc bolus, normal saline, and then sodium bicarb, 8.4 ml percent, 50 ml sodium bicarb IV. If the patient has arrhythmia, it will be 100 ml. I said arrhythmia. So cardiac arrest more than arrhythmia means it's same 100.
Yes.
What else? Magnesium sulfate, 2 gram IV. Okay. Then you will go for intralipid. Intralipid, 1.5 ml
Per kg.
1.5 ml per kilogram bolus. Okay. Then
Yeah.
infusion, same dose, 1.5 ml per kilogram infusion over 1 hour, for example. Clear?
Yes, sir.
Okay. So you have 30 seconds and 6 minutes. If the patient has cardiac arrest, same, but it will be unsynchronized. First, it is a shock, 200, 200, 200. Then don't give amiodarone. You can give adrenaline. Okay. What if the patient has seizures? What you will give?
Lorazepam.
Diazepam or lorazepam. Okay. Don't give phenytoin.
Anytime.
Okay. Excellent. You have 30 seconds and 6 minutes.
Yes. Good morning. I'm Dr. Muzamil, the ED registrar. May I know your name and grades, please? Nice to meet you, both of you. Are you both ALS trained? Please prepare airway and circulatory equipment. We are getting one patient who is having tachycardia and low blood pressure. Has the patient arrived?
Patient arrived.
Any handover from the ambulance crew?
Yes, doctor, we found this patient with this tablet, amitriptyline. What is this?
These tablets usually is a TCA, and it is an antidepressant. And in this tablet can cause, if overdose, can
He
cause.
did not ask you. He did not ask you. You can go.
Okay. Is the patient conscious?
The patient is conscious.
Is the airway patent?
Patent.
Okay. Please apply high flow oxygen and expose the chest. Connect to all the monitors. What about the SpO2?
SpO2 is 94.
Okay. What is the respiratory rate?
40.
How about the tracheas? Is it central?
Central.
Neck veins?
Normal.
Inspection of the chest?
The junior doctor is asking you how this affects the patient, doctor.
This can cause CNS excitation or CNS depression, and in the heart, it can cause arrhythmias. Okay, can I proceed? So, palpation of the chest?
Normal.
Auscultation of the heart and lungs?
Normal.
Okay. Please call the ICU team. It could be because amitriptyline is there. It could be an overdosage of amitriptyline, and call. We may contact hospice as well, depending on the findings further. On the circulation, what about the blood pressure?
Blood pressure is normal.
CRT?
Normal.
Peripheral pulses?
Normal.
Heart rate?
This is the ECG from ambulance crew, doctor.
Oh, guys, this patient is having TCS toxicity, dominant R wave in AVR, white QRS complex with first degree heart block. So please contact hospice and call the ICU team. Guys, the patient is in VT now. So please put 2 IV bore cannulas, extract blood for hematology, biochemistry, blood gases, blood culture, toxicology screening, and please give IV fluids 500 ml normal saline, 3.4% soda bicarb, 100 ml magnesium sulfate 2 gram, and intralipid 1.5 ml per kg body weight. Let us continue with this treatment and let me continue my assessment. What about the disability? What GCS?
GCS is 15.
Okay. What about the pupils? Any lateralizing signs?
Equireactive.
Blood sugars?
5.
Okay. Expose the complete body and look.
Patient is seizing now.
Oh, the patient is seizing. Please, nurse, give 0.1 mg per kg body weight lorazepam. And let me continue my assessment. What about the temperature?
Temperature is normal.
Okay. Has the ICU team arrived? Did we contact Oxbase? I want to hand over my patient to the ICU team. Nobody arrived. Let me reassess. How about the airway?
The airway, the patient already sedated.
Okay. And what about the SpO2?
SpO2 94.
Okay. And what about the blood pressure?
Blood pressure is normal.
What about the rhythm? The heart rhythm, the monitor is same VT. Patient is in VT, so we have already given the treatment, the pharmacological. Then we will go for electrical cardioversion. Please, sister, give synchronized DC shock, 120 joules. Shock given. How about now? Signs of life, pulse is there.
Yes.
How about the rhythm? Rhythm is same, so we will give another DC shock, synchronize 130 joules. All clear, shock given. How about signs of life? Look, listen, any pulse is there?
Yes.
Okay, so reading the rhythm, again the rhythm shows VT. So please, sister, give another shock, DC shock, synchronize 150 joules. Shock given. Okay, how about now? Any signs of life? Pulse is there?
Yes.
Okay, so patient still in this one VT, but amidron is contraindicated. We can give adrenaline 1 mg IV. No, we will just give we'll just continue our assessment. Continue fluids. We can start intralipid 1.5 ml per kg as an infusion over 1 hour. 1 hour passed. How about this the rhythm now?
The patient is unconscious now, and the patient is unresponding.
Look, listen, and feel. Any signs of life?
No.
Oh, sister, patient is in cardiac arrest. Call the adult resuscitation team and start high quality CPR, 30 compressions followed by 2 breaths. We have to assist 4H and 4Ts.
Thank you. Your time done. Okay, thank you. So the patient is stable. I give you the patient. Sometimes the patient is drowsy, or drowsy maybe 14 GSS, or maybe the patient is fully conscious. It means 15. Stable, vital signs normal. VT, so the patient has a stable VT. You started pharmacological treatment. Pharmacological treatment, it means you should give the 4 treatment. It means fluids, magnesium sulfate, sodium bicarb, magnesium sulfate, and intralipid. Then you found the patient has seizures and disability. You give 4 milligram. In pediatric, you can say 0.1 milligram per kilogram, but in adult, 4 milligram. Clear?
Okay, sir.
4 milligram. Okay, will be bolus. So regarding this patient, conscious or unconscious? Unconscious. The patient had seizures.
Yes.
So he was conscious, but now he's unconscious, right?
Yes, sir. Yes.
The patient is in seizures. It means became unstable. Easy?
Yes, sir. Unstable.
He was stable and then turned to unstable. It means you remember in reassessment, if you find the VT, you will give this a shock. Okay. You will give this a shock even he is stable or unstable in the second assessment because failed pharmacological treatment and because he became unstable, right?
Yes, sir.
Okay. So you did well. This patient in cardiac arrest, you can give the first dis shock, then the second dis shock, then the third dis shock. Don't give amiodarone. You can give adrenaline. But in cardiac arrest, okay, if the patient is alive, don't give adrenaline. Okay, well done. I will give you 9 out of 10. Thank you.
Thank you, sir.
Next one, Anwar.
Yes, Dr. Hani. Omar?
Anwar.
Yes, I'm here, Dr.
Anwar.
Hani.
I hear the Omar. Yeah, okay,
Okay.
sorry.
So the next station, the patient is using antihypertensive medications. So you are once you see that in the scenario, you are expecting calcium channel blocker or beta blocker. Clear, Anwar?
Yes, doc.
You are expecting bradycardia. What is the first treatment for bradycardia?
Atropine.
Atropine. Even not effective, but this is the rule. What you can do? Nothing. Atropine. Atropine, you will give 0.5 milligram 6 times. Every 5 minutes, repeat. It means you will wait for 30 minutes, right?
Right, doc.
6 times equal 30 minutes. So you will start transcutaneous pacing after 30 minutes. But this is not logic in the exam. Okay? So here, if you find the patient has bradycardia, so what about airway? Normal. Breathing? Normal. Circulation? You find the patient has, for example, normal blood pressure, normal CRT, and peripheral pulses. And this ECG. What is the diagnosis in this ECG?
So it looks like complete heart block.
Okay, complete heart block. So you have 8 indications to give atropine. I'm talking about the old guidelines, and then I will say the new guidelines, and no difference between both, no problem. So you have 8 indications to give atropine. Number 1, shock. Number 2, syncope. Number 3, myocardial ischemia. Number 4, signs of heart failure. Then number 5, risk of systole, like the patient has recent systole. Next one, the patient has complete heart block with white QRS, white QRS. Okay. What else? Ventricular pause more than 3 seconds and Mobitz type 2. Clear?
Yes, Dr.
It means the second degree. If I say Mobitz type 2, I'm talking about which degree?
Second degree heart block.
Second. Okay. Because second degree, you have Mobitz type 1, Mobitz type 2. So if I say Mobitz type 2, it means second degree. Okay, good. So how many indications for atropine?
8 indications.
8. 4 and 4. 4 signs of instability. 4 signs of instability. And the 4 signs of risk of systole. Clear?
Yes, Dr.
Okay. So the new guidelines said if you find risk of systole, start transcutaneous spacing, first action. Which one to follow? It's up to you, don't worry. Clear?
Yes, Dr.
You want to give atropine and attach transcutaneous spacing? Okay. Anyway, transcutaneous spacing will take time. When you attach the pads, when you start the pacing mode, you will give also, you will start the 0 milliampere, you will start by 10, 20, 30, 40, 50. Okay. So you have two parameters here, the pulse and the milliampere current. So 70, once you turn on the mode, so you have here pacer, you have off, you have on. Okay. So once you turn on the pacer, you will find the monitor like that. You will find here 0, you will find here 70. Don't touch 70. You will control only the milliampere, the current, the electricity. Okay. Start by 0, then 10, 10, 10, 10, 10, 10, until you find basing, the spike. This spike is artificial. These waves for the heart, this normal, natural, but this one artificial. Clear?
Yes, Dr.
These spikes artificial. So spikes, it means electrical capture? No. So if you find the spikes, you can say the patient has basing rhythm, basing rhythm. Okay. So if you find spike, 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 okay, you can say the patient has basing rhythm, but no electrical capture. Why? Because no waves here, no waves here, right?
Right, Doctor.
So if you find spike followed by waves, spike not followed by waves, it means no electrical capture. So what you will do, increase 10 and check, still no waves. 30, still no waves. 40, still no waves. 50, 60, 70, 80. Then you find waves, 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 waves. Each spike followed by waves. So the patient has pacing rhythm followed by waves. It means with electrical capture. Clear, guys? Okay. What is the next action?
Arrange for transvenous spacing. Involve the cardiologist.
Mechanical capture. Check mechanical capture. So if the patient has electrical capture, it means electrical activity. Then check for mechanical capture. What does it mean, mechanical capture? A, B,
Pulse.
C, D, E. A, B, C, D, E. It means check the airway, check the breathing, circulation, disability, exposure. Okay? Okay. So here regarding beta blocker or calcium channel blocker, already we give atropine in the first circulation. Already we attach transcutaneous spacing in the first circulation. Then give antidote. So if the patient is stable, no need to give fluid. It's not a big issue. Why you will give fluid? No need. You will give antidote? Yes. What is the antidote for calcium channel blocker? calcium chloride, 10, 10, 10. What else? Insulin dextrose. Insulin, you will give 0.1 unit per kilogram, and dextrose 50 ml, 50%. Okay. Then you will give what else? Glucagon?
Glucagon.
Yes, glucagon. Okay. Glucagon, you can give IV 5 milligram. IV 5 milligram. Okay. So what if the patient has beta blocker? Same. You will give insulin dextrose. Insulin dextrose. You will give also glucagon. But you will not give calcium chloride because calcium chloride only for calcium channel blocker, right?
Right, doctor.
Okay. You can give intralipid? Yes. No problem. You can give intralipid if not responding. Okay. You have 30 seconds and 6 minutes.
Okay, can I start, doc?
Yes, please.
Good morning. I'm Dr. Anwar, one of the registrars here. May I know your name and grade, please? Okay. I guess you all are ALS providers. I need one nurse to take care of the airway and one for the circulation. We're expecting a patient and we suspect he's overdosed on a medication and antihypertensive medication. Has the patient arrived?
Patient arrived?
Okay. Any handover from the ambulance crew?
Yes, doctor. This patient, we found him collapse at home and he's using diltiazem, this one. What is this?
It is used for high blood pressure.
Yes, what is this?
It is a non-dihydropyridine beta blocker, calcium channel blocker.
What is calcium channel blocker?
Yes.
Okay. How this affect the patient?
Calcium channel blockers can reduce myocardial contractility, cause bradycardia,
Be simple.
bradycardia and hypertension. Yes.
Okay.
Okay. Is my patient conscious?
The patient is conscious.
Is the airway patent?
The airway is patent.
Okay. Please attach high flow oxygen. Let's move on to breathing. Please expose the chest and connect all monitors. What is the SpO2?
SpO2 is 9.4.
RR?
RR is 40.
Is the trachea central?
Yes,
Any distended neck veins?
normal.
Auscultation of the chest and lung sounds?
Normal.
Inspection?
Normal.
Palpation?
Normal.
Percussion?
Normal.
Okay, so our patient is tachypneic. Let's move on to circulation. What about the blood pressure?
Blood pressure is normal.
Okay, what about the capillary refill time?
Normal.
Peripheral pulses?
Normal.
What about heart rate and rhythm, please? Can I check the monitor? Okay, guys, this looks like severe bradycardia, and patient has got wide QRS complexes, PP and RR interval is fixed, and there is AV dissociation. This looks like a picture of CHB. Please attach two large bore IV cannulas, extract blood for hematology, biochemistry, blood gases, blood culture, toxicology screen, and please contact the ICU team and the toxicology base and the cardiologist. Please, nurse, give 0.5 milligrams IV atropine bolus and attach transcutaneous pads. Do not start, please just attach the pads. Can we move on to D now? Given the background of calcium channel blocker toxicity, this could be an overdose of calcium channel blocker. So please also give nurse 10 ml of 10% calcium chloride IV. And let's start an insulin drip in the dextrose, 50% of 50 ml dextrose, and let's put 0.1 unit per kilo insulin. And then let's move on to the disability. What's the GCS of the patient?
15.
Okay. What's the blood sugar of the patient?
5.
Any signs of lateralization?
Normal.
The pupils equal and reactive?
Normal.
Okay, let's move on to exposure. Please expose the patient. Any other abnormalities noted? What about the temperature of the patient? All right, guys, we need to contact the ICU team and the toxicology base and the cardiologist. And has anyone arrived? Okay, so let's go to reassess our patient. Is the airway still patent? Okay, let's move on to breathing. What's the saturation and the RR? Okay, is the blood pressure normal of the patient?
Yes.
Did the heart rate improve or it is still the same? Okay, if 5 minutes have passed and the rhythm is same, please nurse administer 0.5 milligrams of IV atropine once again and reassess the rhythm.
3 milligram given already.
Okay, if 3 milligrams have given and patient is not responding, the patient has got refractory complete heart block, and this is high risk for asystole because of the wide QRS. So please let us start transcutaneous spacing, attach the pads, and set the milliamperes, and let us start transcutaneous spacing. Can we see the pacing spikes? Okay, we cannot see the spikes. Please increase the milliamperes in intervals of 10, please. Okay, I think this is undersensing. We do not have a QRS followed by every spike. So please increase the milliamperes again by 10. Let's go to 20, 30, 40, 50, 60. Turn it up to 70. Okay, can we increase to 80? Can we go up to 90? Okay, we are still seeing pacing spikes, but there is no, every spike is not followed by a QRS complex. Can we increase some more? Okay, can we go to 90? And we go to 100? Okay, please check the position of the pads once again. The right pad should be below the right clavicle and the left one at the apex of the heart below the left nipple. Okay, can we increase some more? All right, patient is not, there is no mechanical, can we check for mechanical capture? Can we reassess
Okay, thank
ABCDEs
you.
again?
Thank you. Okay, your
No
turn
problem.
done. The patient has spikes, right?
Yes, doctor.
If the patient has spikes, it means the pads are connected, right?
Yes, doctor.
So don't think about the pads. Then what you will do if you find the spikes? Increase.
Yes, doctor.
So you started by 10, you find the spikes. It means everything is correct.
Okay, doctor.
So the patient has bradycardia. This bradycardia, 0. The milliampere 0. This is the normal ECG, right?
Yes, doctor.
So 0. Then you will start at 10. You find this one, spikes. It means the pads are connected, right?
Yes, doctor.
Then increase 20, 30, 40, 50, 60, 8, 70, 80, 90, 100, 110, 120, 30, 40, 50, 60, 200. Did you reach the maximum? Not yet. Clear?
Yes, doctor.
So you can increase until you find what? Waves after each spikes. Easy?
Yes, doctor.
Once you find electrical activity like that, waves, 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 then, for example, you found these waves, for example, at 130 millicurrent. Okay. What you will do? Ideally, you should increase
Increase 10.
10 or 20 above the previous one. Clear?
Yes, doctor.
Okay. What if you did not increase? Don't worry, no problem. You can continue. Okay, so don't check mechanical capture if you don't have electrical capture. Clear?
Yes, doctor.
This ECG, no electrical capture. This ECG, you have electrical capture. So if you have electrical capture, check mechanical capture. If you don't have electrical capture, you have to increase until you find the electrical capture. Clear?
Yes, doctor.
Okay, I will give you 7 out of 10. Thank you.
Thank you, doctor.
So you did well in the algorithm, the approach, and just as the transcutaneous spacing, you need to hand over this patient to cardiologist for what?
For transvenous spacing.
Yes, for transvenous spacing. Excellent. Okay. Next one, Omar. And if he ask you this delta then what? No need to be overthinking, Anwar. Okay. So
Yes, doctor.
you can say calcium channel blocker done. How this affects the patient? It will cause what? Bradycardia hypotension.
Radical.
Will it affect the patient? Yes, it can cause CNS depression. It can cause brain. It can cause heart uh, depression. Depression, it means hypotension and bradycardia. Clear?
Yes, doctor.
So depression here, depression here. Done. Okay. So these all the guidelines. So they said if you have risk of a systole or you have signs of instability, you will give atropine. The new guidelines said risk of asystole, jump to transcutaneous spacing. If you have signs of instability, jump to atropine. So you can follow any of them, don't worry. Okay, next
Okay.
station. Omar. Omar, you are muted. Can you hear me, guys?
Yes, doctor.
Yes,
Yes.
doctor.
Okay, Kalyan.
Hello, sir.
Yes. Are you happy to practice this one?
Yes, sir.
Okay. So this patient overdose. Overdose, we are not sure about the overdose now. Of course, they will give you any clue. If they did not give you any clue, you will catch it from assessment. So this patient, if they give you RR is 4, you think about what?
Bradypnea.
Yes, you think about
Opiates.
opiate, opiate toxicity.
Opiates.
Okay. So don't talk about opiate toxicity in breathing. You will catch the diagnosis in which system?
Disability.
Disability. Okay. So if you catch the diagnosis in disability, it will be diagnosis in disability, treatment in disability, then you will reassess every disability. Clear?
Clear, sir.
For example, previous station, the patient has bradycardia because of calcium channel blocker or beta blocker. You will catch the diagnosis in circulation. You will give the treatment in circulation. You will do assessment every circulation. So in atropine, you are doing assessment every how long?
2 minutes.
5
2
minutes.
minutes.
5 minutes. I'm talking about atropine. I'm talking about
Uh,
atropine. Every
Atropine.
5
Atropine.
minutes. So in this station, different. You are assessing the patient every 2 minutes. So you will give the naloxone in disability and you will reassess the patient in next disability after 2 minutes. So if you go for next disability, you should verbalize 2 minutes past. Easy?
Okay, sir.
So every disability, you will say 2 minutes past. What about GSS? What about pupils? What about blah, blah, blah. Clear? Okay,
Okay, sir.
well done. So if the patient has RR in breathing, low, in disability, the patient has GCS low, for example, 14 or low, then pupil pinpoint, then you will verbalize the patient has triad of opiate toxicity. Okay, so start
Okay.
naloxone. So you will call ICU team, contact toxicase.org. You will start naloxone infusion or bolus. So bolus 400 microgram. Then And next assessment, if you find no response, what does it mean no response? R same. I said same. Just as same. Pinpoint pupil, same. Then you will give bolus. Next assessment, same, bolus. Next assessment, same, bolus. Easy?
Okay, sir.
When to start infusion? If you find any response. I said any response. Any response in breathing, any response in GSS, any response in pupil. Clear?
Okay, sir.
I mean any response, even partial response. You should start infusion. I wish it's clear.
Yes, sir.
Failed, it means bolus. Partial response or response, it means
You can
Infusion.
infusion. 60%
infusion.
of the risk.
Means infusion. Okay. So infusion, how much? 60% of previous doses. 60% of
Rescue dose.
rescue doses. It means the previous doses. So if you give the patient, for example, 3 doses, after that, please mute your mic guys if you have noise. So you will start 60% of the rescue dose. Rescue dose, it means the total previous doses. If you give only one dose, it will be 60% of one dose. If you give 2 doses, it means you will give 60% of the previous 2 doses. Clear, Kalyan?
Okay, sir.
Okay. If you are happy to start, you can start.
Hello, I'm Dr. Kalyan, ED registrar. May I know your names and grades, please? Are you ALS trained? Can you please manage airway and prepare airway equipment? And can you please manage circulation and circulation equipment? We are about to receive a patient with overdose. Let the patient arrive.
Patient arrived.
Any handover from the ambulance? Any handover from the ambulance crew?
Yes, we found this patient in the street. He collapsed and he has, I think his clothes are dirty.
Okay, thank you. Is the patient conscious?
The patient is unconscious.
Look, listen, and feel. Any signs of life?
Yes.
Is the airway patent?
Yes.
Apply high flow oxygen. What about expose chest and connect all monitors? What about SpO2?
SpO2 is 80.
Respiratory rate?
RR is 4.
Trachea?
Trachea is central.
Neck veins?
Neck veins are normal.
Any abnormality on inspection?
Normal.
Palpation?
Normal.
Percussion?
Normal.
Auscultation of lungs and heart?
Normal.
Patient is having low oxygen saturation and bradypnea. Please call ICU team and contact top base. It will be overdose. And start bag wall mask ventilation. Patient is in bradypnea. So call anesthesia also. He might need intubation, do pre-oxygenation, and I'll move to circulation. What is the blood pressure?
Blood pressure is not recordable.
Look, listen, and feel. Any signs of life?
Yes.
CRT? Peripheral pulses?
Weak.
Heart rate and rhythm? heart rate is 77, and the patient has signs of life. Patient is having low blood pressure. Patient so call ICU team and give 500 ml IV bolus NS, and insert IV cannula, extract blood from for hematology, biochemistry, blood gases, biochemistry, toxicology screen, blood culture, and I'll move to disability. GCS. What's the GCS?
GCS is 13.
Any signs of lateralization?
No.
What about pupils?
Pinpoint.
What about blood sugar?
5.
Okay. The patient is having pinpoint pupils. GCS is low. So this is a patient is having triad of opiate toxicity, bradypnea, low GCS, and pinpoint pupil. It could be opiate toxicity. So call ICU team, contact tox base, start give antidote naloxone 400 microgram IV bolus. So then I will move to exposure, expose all body, any abnormality, any other abnormality. What's the temperature? I would like to hand over the patient to ICU team. Did the ICU team arrive? I will reassess the patient. Is the patient conscious? Is the airway patent?
The airway is patent.
Did oxygen saturation improve?
Yes.
What about respiratory rate?
4.
Continue back wall mass ventilation, call anesthetist, and BP, blood pressure. Did the blood pressure improve?
Yes.
What about GCS?
Same.
Uh, uh,
Thank
pupils?
you. Thank you. Your time done.
Okay.
Okay, thank you. You are doing well, but I can see you are sleeping. This is resuscitation or history taking?
Okay, sir.
Okay, Karim. You are doing well, but okay. So this station, you will catch the diagnosis in disability, and then you will do reassessment every disability. So the patient has same criteria, same findings, same RR, same GSS, same pinpoint pupil. So what do you think? You will give bolus or infusion?
Bola.
Bolus. So each time you find the same, bolus. I mean same criteria. If you find any change in the criteria, what you will do?
Start infusion 60% of
Yes,
rescue dose.
excellent. Excellent. Okay. So if you find this patient at any time in cardiac arrest, okay, so you will start high quality CPR. So activate cardiac arrest call the adult resuscitation team, start high quality CPR, and then ventilation 32.2. Then you will consider for H40. The most likely problem is
Toxin.
T toxin.
T.
Okay. So you will reverse, you will not get ROSC until you reverse the cause, right?
Yes, sir.
So you should give the antidote in cardiac arrest. So you will start naloxone. Okay. Even you give before, yes, in cardiac arrest you have to repeat, and then you will give fluids also. Then after ROSC, you have to reassess the patient. If you find the patient after ROSC became better, then start infusion again. If you find the patient has same problem, then it will be bolus again. Easy? Okay.
Okay, sir.
I will give you 8 out of 10. Thank you. Next one, Emmanuel.
Thank you.
Yes, sir.
Okay. Next station. Here, the patient was doing sutures with your colleague and suddenly collapsed. So, what is the likely problem?
Toxicity to
Local anesthetic
local
toxicity.
anesthetic.
Local anesthetic toxicity. So, maybe the patient collapsed and still alive, or maybe in cardiac arrest. Okay.
Yes, sir.
Okay. So, if you find him collapse and still alive, what you will do? Oxygen, fluids, and interlipid.
Yes, sir.
1.5 ml per kilogram bolus, then followed by the same dose but infusion over 1 hour. If you
Yes, sir.
find the patient cardiac arrest, you will give
Bolus.
bolus. Okay.
Yes, sir.
So if you find the patient cardiac arrest in the beginning, it means the first cycle. Don't ask about 2 minutes until you verbalize everything.
Yes, sir.
Okay. You have 30 seconds and 6 minutes.
Sure, sir.
Don't give amiodarone. Don't give
Agree.
lidocaine.
Yes, sir. Okay.
You have 30 seconds and 6 minutes. If you are happy to start, you can start.
Hi, good afternoon. I am Dr. Emmanuel. I am one of the ED registrars and team lead for today. We are expecting a patient by name Mr. Brain, 37 olds.
Doctor,
He's
the patient here, I'm the junior doctor. I was doing sutures and I found the patient collapse. What is the problem, doctor?
okay. Is the patient conscious?
What is the problem, doctor? What happened to him?
Most probably it could be a toxicity to local anesthetic agent.
Okay, okay.
So, is the patient conscious?
The patient is unresponding.
Oh, sorry to hear that. Look, listen, and feel any signs of life?
No signs of life.
Oh, staff, team, the patient is in cardiac arrest. Please activate ALS code and immediately connect to the monitor and start high quality CPR 30:2 ratio ventilation compression. May I know the rhythm on the ECG monitor? Oh, patient is having ventricular tachycardia on the rhythm. Prepare for shock and continue CPR for 2 minutes. 2 minutes pass. We'll think about reversible causes. So most likely it is like H toxins. So we'll give secure IV cannula and we will give intralipid 1.5 ml per kg bolus followed by IV fluids and give soda bicarb 100 ml as well. Any pulse? Checking for pulse?
No signs of life.
No signs of life. Continue CPR and prepare for shock.
Shock, what do you mean by shock, doctor? How much synchronized to unsynchronized? How much joules?
Unsynchronized
Monophasic or biphasic?
monophasic
Biphasic,
DC,
doctor, biphasic. So you will give
maximum joules of biphasic.
200 joules biphasic.
Yeah, 200.
Unsynchronized.
Yeah, 200 joules by biphasic unsynchronized shock. Shock delivered. Continue CPR.
Continue CPR for how long?
Hello, sir. Your voice is breaking.
your signal problem.
Sir.
Can you hear me clearly, guys?
Yes, doctor.
So
Yes, doctor.
the problem from your side, Emmanuel.
I'm sorry, sir.
Okay.
Checking for pulse,
The patient has no signs of life.
continue CPR, and second dose of shock preparation going on, and give 1 mg of IV adrenaline as well. We will start with the intralipid 1.5 ml per kg IV infusion because he is not responding for the bolus, and continue IV fluids. 2 minutes pass. Any change in the rhythm? Checking pulse. No pulse. Continue CPR and prepare for a third shock. And continue IV, intralipid bolus and give IV fluids as well. Third shock delivered. Resume CPR and checking for pulse. Hello.
Yes, continue, doctor. If the examiner is ignoring you, continue. So the patient has no pulse now. What you will do?
Yes, sir. Continue CPR. Two minutes pass. Any change in rhythm and any checking pulse?
The patient has sinus rhythm now. The patient, sorry, has signs of life now.
Signs of life. Oh, patient is having a pulse and as well as rhythm is showing ventricular tachycardia with pulse. We will start giving a synchronized cardioversion of 120 joules. Continue CPR and prepare for shock and give the shock. Shock delivered. Continue CPR.
Okay, thank you, doctor. Your time done. Okay. So you are saying shock. Shock not enough. Should be synchronized or unsynchronized. You should mention the joules. If synchronized, you will start by 120, then 130, then 140. If the patient is in cardiac arrest, it will be 200 joule by physic, then 200, then 200. Okay. You will give, in cardiac arrest, you will give adrenaline after third
Second,
shock. Third
second
shock.
shock.
Third shock.
Okay.
Your exam is UK exam, so you should follow the UK guidelines, not the American guidelines. Okay. So
Good,
you
sir.
should give the DC shock, DC shock, DC shock, then adrenaline, then amiodarone. Adrenaline in one arm, amiodarone in the different arm. But here contraindicated amiodarone, okay?
Yes, sir.
Because of sodium channel blocker. Okay.
Yes, sir.
So here I said in the first cycle, don't ask about 2 minutes until you
Yeah.
verbalize everything, but you did not listen. You are not listening.
Yes, sir.
So is the patient conscious? Unresponding. Look, listen, and feel. Any signs of life? No signs of life. So verbalize the finding. The patient is in cardiac arrest. Then call. Call cardiac arrest call. Activate cardiac arrest call. Start high quality CPR, not CPR. High quality CPR. High quality CPR, it means everything is perfect.
Yes, sir.
Start high quality CPR, 32-2. Attach back valve mask. Okay. Give two ventilation every 30 compression. Then what you will do? Attach monitors. Check the rhythm. Don't comment on the rhythm now. You said attach the monitor, check the rhythm, done. Then continue. Insert to IV access, extract blood for hematology, biochemistry, blood gas, blood culture, toxicology screen. Okay.
Yes, sir.
Then I will consider for H4Ts. The most likely problem is T toxin. It could be local anesthetic toxicity after lidocaine injection. Okay.
Yes, sir.
Then what you will give?
Intralipid.
Intralipid. Until now, I did not ask about 2 minutes. Give
Yes, sir.
intralipid 1.5 ml per kilogram bolus and give fluids 500 cc normal saline. Okay. Then nothing else to do, right?
Yes, sir.
Okay. So you will give shock. Give DC shock. How much?
200 joules.
200 joules unsynchronized by physics. You should mention that.
Yes,
Okay.
sir. Yes, sir. Yes,
Shock
sir.
given. Resume. Resume. What?
Operations.
Resume high quality CPR 2 minutes. Okay. Then 2 minutes passed.
Hello.
Just listen to me, Emmanuel. Your voice is distorted
Hello.
because your signal. Just listen to me. No need to talk, please. So, can you hear me clearly, guys?
Yes,
Yes,
Dr.
Dr.
Hani.
Okay. So, once you finish everything, you verbalized everything, nothing else to do because you did everything. You inserted cannula, you extracted blood, you gave this a shock, you considered for H4Ts, you check the monitor, you did everything. Then here you can ask about to me. But the big mistake, the fatal mistake, you just received the patient. Is the patient blah blah blah? The patient in cardiac arrest, 2 minutes past. Why you are asking about 2 minutes? You are expecting ROSC without giving shock. You are expecting ROSC without treatment. You are expecting ROSC without reversing the cause. You are expecting ROSC just by your intent. No, you will not get ROSC by your intent. Okay,
Yes, sir.
so you should verbalize everything. And when you verbalize anything, try to verbalize complete, simple, concise. Complete doesn't mean talk too much, no. Complete may be concise. If I say synchronized 120 joule by phase. If I say unsynchronized 200 joule by phase. Resume 2 minutes high quality cigar. Should be like that. Okay. Okay, I will give you 6 out of 10. 6 out of 10. Thank you.
Dr. Hani,
Yes, please.
question please about epinephrine. You said after third shock. It is in all cardiac arrest or in this case only?
In all cardiac arrest.
I
What?
think before in previous record we said activate high start CPR then give epinephrine. So after third shock. طب if the patient is non-shockable
And if non-shockable, start as soon as possible.
as soon as possible. So in shockable rhythm only after third shock, not after second shock.
No, after third shock. UK after third shock. In American after second shock.
Okay,
Okay.
thank you.
We will stop here, guys, because of prayer time. Okay. Uh, I'm sorry, unfortunately, you are not preparing well. If you are preparing well, we will save time. Even if I'm explaining, you are not listening. This is bad. Anyway, we will stop here. We can do a brief session tomorrow. Brief session tomorrow. It will be 1 p.m. UK time. Okay, guys. We will do the 5 or 6 stations of resuscitation. The last 5 or 6 stations. Okay.
But we will keep our rules in practicing.
What do you mean?
our ترتيب
Your
practicing.
okay. Your turn. You mean?
Yes.
Okay. So Omar Obeid, you did not practice. You can start the first stations. Okay.
Okay. Thank you.
Tomorrow after prayer, Jum'ah. Okay. So we will start 1 p.m. UK time. and we will start like 5 or 6 stations only. Thank you guys. Bye bye.
Thank you.
Thank you.